And the last one, we will give voting for that lecture for these cases. So we'll see, give some interaction. So we are testing this one first time in our webinar. It was tested by other webinars, and I think it's something good for the young trainees and young neurosurgeon to be part of it.
Imad, we're using a slightly different system, so it's more in real time.
Real time, okay.
Well, let's try. We'll see. Yeah.
Is it more than real time?
It's definitely not more than real time.
That would have to be neurosurgical time, right?
Yeah, indeed.
So, Tom, perhaps I will give that short introduction and the conclusion, and then I will give over to you and Salman. So perhaps you divide the moderation, both of you, or you do it together, whatever. I felt it's good to have half of it you and half of it the other half with Salman, or you alternate accordingly, according to your time schedule. I don't know.
Or maybe, I'm sorry, maybe three of us? No?
Okay.
One, two, three,
So
one, two, three.
I will start. I'll do the Pablo and Anil, and then you take over. 3 you and 3 for Salman.
Okay. Okay, maybe I'll do the last 3 ones or something. Yeah.
Okay. Wonderful.
Hello, dear friends. How are you?
Hi, Victor. How are you?
Hi, Victor.
Hi, fine.
Hello.
How is everything, Victor, in Mexico?
Almost six person died. Some damage to some buildings, especially in the southeast, but it's okay. No big problem. That earthquake was 7.5 in the Richter scale, so it was a strong earthquake, but damage was little, fortunately.
You're okay, that's good.
Yeah, most of the people are okay.
Kiki sent a message. He is with us today, he said.
Perfect.
Is he coming or he's not coming?
And he wrote a nice wording yesterday on WhatsApp. He was impressed.
Yeah, I think it's quite nice of him to do that.
He's not here yet.
How are you, everyone?
Hey, Kasadi, how are you?
Hello, Kasadi. How are you?
Good. Nice to see you all.
Thank you.
Right.
Which was this? Same meeting.
The same one?
Second session.
Okay.
Ramesh, tell Nigel we said hello.
Yeah. Sanjeev is here.
You mute?
No, I'm not mute. I think Sanjeev is...
You're definitely not muted, I can tell you that.
But you're not moving. Maybe you're doing that on purpose, I think. Staying still.
Frozen.
Salman, hello.
Hi, Salman.
Salman. Hi, Ramesh. How are you? Sorry.
Yeah, not too bad. Yes.
Setting it up.
How's everything? What happened to you yesterday?
Oh, I was doing an aneurysm, sorry. And so it just went on a bit long than I expected. And then I thought it was a bit too late. I was tired, so I got some sleep.
What's the name?
I just sent it to the group.
Can you hear me?
Yeah, we can hear you.
Sent it to the group just now.
Yeah.
Are we all set to go?
We got another few minutes.
Two more minutes, yeah.
Hi, Ahmad. How are you? Sorry, I got stuck with an emergency aneurysm yesterday. I
I
apologize.
understand, no problem. But today you are with us anyhow, and you are co-moderating with the team, with Tom and myself. So most probably I will, for Salman, I'm going to present the first two, and then you take care of the next three, and Tom has taken the last three.
Okay,
As
done.
moderator. Okay.
Hi, Salman. All right.
And remember to check the chat for
Hi, how are you, Tom?
questions.
How's it going?
Not too bad. I just to make you feel better, I also finished around midnight last night. So
Yeah, actually, quite glad to hear that.
Yeah, we are really very happy that you did it that as well, because you know you're all neurosurgeons, you're used to it now.
I think should we go ahead? 1
We
minute,
have 2 minutes to go, Ahmad.
2 minutes. Yeah, we'll wait for that. Yeah, so they can.
No worries. How's it going, Ahmad? Looking good?
Well, thank you. Yesterday's session was good, except that microphone of one of the speakers was not working very well. But
I heard. Yeah, I heard.
we will compensate for him in the future.
Sure. Sanjeev,
I
all
said
good?
I said we are doctors. We cannot practice without complication, and we are not any better with the webinars.
Indeed. That's all good.
We just need to be prepared for it, and that's all.
That's correct. Yeah.
Mr. Kirola's talking to his stockbroker then.
Sure.
it's organizing dinner.
Yeah.
I think we will start, and good day. I like this statement, good day from the Australian. This is the best because it fit anytime, east, west, and central. And we have the second day of the neuroanatomy, neurosurgical webinar. Yesterday was a successful one, and I hope today we have a long program and we're exciting invited faculties. I'd like to just go over the faculties. Professor Pablo Gonzalez will be the first presenter. He will be come from Alicante. He is at the University of Alicante and will be followed by Dr. Anil Nanda from New Jersey and Dr. Roy Daniel from Switzerland. They are all professors. They have a leading position and they are experts in their field. Dr. Ji Tang from Beijing, China. Dr. Eckhart Kasper from McMaster, Canada. And Dr. Miguel Reyes from Malaga, Spain. And Dr. Sebastian Foresh from France, Paris. And then concluded with Professor Sanjeeva from England. The talks will cover orbital tumor to start with, and then we'll go over the skull base from the front to the back to the foramina. And everyone is dedicated to 20 minutes for the presentation and 5 minutes for taking your questions. So please leave your question on the chat. We'll try to answer some of them during the sessions, and some of them, they will be answered by the faculty along the Q&A. And the last presentation of today will be an interactive sessions showing some cases, and we'll try to take a vote to see the common practice. We learned this from Professor Sharif from his webinar. My colleague, Professor Benish, and myself, we welcome you on behalf of the Neuroanatomy Committee and the World Federation of Neurological Surgeons. We start the session with Professor Pablo Gonzalez.
Thank you, Imad.
Sorry, I forget to tell you that we always miss something. I am co-moderating this one with my colleague, Professor Thomas Anterior, and Professor Salman Sharif. Professor Anterior is from the Oxford Group in England, and Professor Salman Sharif from Karachi, Pakistan. Both they will co-moderate these sessions, and feel free to interact with us. All right, we'll start. Professor Gonzalez.
Let's go. So you let me know if you can see my screen. Good. Okay.
Yes, perfect.
Thank you again for taking your time to be here with us. Thank you to all the friends in the committee, because this is becoming a really exciting project, as we cannot meet together somewhere in the world. But I'm so happy to continue being part of this amazing group of friends. And I have to deal with the orbit anatomy. And my plan is to try to share with you what I have been learning after doing dissections in the lab, studying the anatomy, and how this knowledge can help us to optimize our surgical approaches. So there is something very nice about the orbit. It's a small chamber in which we have many neurovascular structures and some muscles, as we will be discussing. And this is a beautiful paper from the group of Proton, in which they established the so-called rule of 7. So we do have 7 muscles, 7 bones, and 7 nerves, which will be discussed properly. Well, the first concept is that the orbit should be understood and its contents as a prolongation or elongation of the central nervous system, which is located in anterior skull base. And as we can see here, the dura mater, which is the covering of the intracranial space, becomes the so-called periorbita, which is completely enclosing all the structures inside the orbit. Another interesting concept is that once we open this periorbit, we will dive into the so-called yellow sea. This yellow sea is made mainly of fat, which is enclosing and surrounding all these neurovascular structures. But if we take time and remove all this fat, we will uncover the arteries, the veins, the nerves, the muscles, and the globe, which is something that we must try to identify during surgery. What about surgical approaches to the orbit and how we can apply the anatomy for them? So they can be divided in many, many ways, but the best way by far is to understand the anatomy, to have a careful look at your preoperative images, and to decide which is the best surgical route in your hands for your patients. So which are the most common approaches? So for neurosurgeons, let's say that we can perform lateral orbitotomies, pure lateral orbitotomies, or supraorbital orbitotomies, for which we usually need a craniotomy, as we will be discussing. So the important thing is to discuss and to identify which tumor will be better removed through an orbitotomy and which ones will need a craniotomy plus an orbitotomy. Something important about the orbit, and we as neurosurgeons don't realize too much about cosmetic, but it's something very important. And this is how people, normal people, understand the beauty. And generally, this is how most of the neurosurgeons understand a beautiful face. So this is the anatomy that we should try to identify. Let's start with the surgical chamber and which are the surroundings of this orbit. So we have these limits, bony landmarks. So all the walls, the inferior, superior, medial, and lateral walls are made of the ethmoid, maxillary, lacrimal, sphenoid, frontal, palatine, and zygomatic bone. And these are the 7 bones that we should perfectly identify and decide which bones are going to represent our gate to the orbit. So if we have a look from anterior to posterior to the orbit, it can be understood as a pyramid. So it has the base in the most anterior aspect and the apex in the most posterior aspect. So this is the pyramid we will be dealing with. So we do have a base, an apex, and medial, lateral, wall, roof, and floor. This is what we have to know about it. And inside this surgical chamber, this bony orbit, we do have some clefts, mainly in the medial wall. We do have a hole or a foramina for the anterior ethmoidal arteries, which is 21 millimeters from the internal canthus. We do have the posterior ethmoidal arteries hole, which is right here, going to the ethmoid bone. And finally, we do have 7 millimeters posteriorly, the optic canal through which the optic nerve is coming from. So again, the rule of 7 can be understood as we have 21, 14, and 7 millimeters. Let's go to a practical case to understand these bony limits. This is a lady, 35 years old lady, who came with some cosmetic issues and some headache, especially in the supraorbital area. And we can see an hemangioma, which is growing mainly in the frontal bone, so which means mainly in the roof of the orbit. You can see how this is the craniotomy we want to perform, and we want to drill the superior aspect of the orbit. We can see how this cosmetic problem was quite uncomfortable for the lady. And in the past 3 years, she was feeling even some diplopia when she was looking upwards. So the idea is to identify what part of the bone we want to remove. So we did a bicoronal incision. We are going down, trying to identify the supraorbital nerve. Also, another nerve that we must respect is the frontal branch of the facial nerve. So this is, we did this interfacial dissection, and then we try to cut a little bit the temporalis muscle attachment to the zygomatic process of the frontal bone. So this is the lateral aspect. Then with this guide, we decide which part of the frontal bone is invaded by this hemangioma. We do the frontal craniotomy, and then we will go to drill the part of the hemangioma inside the roof of the orbit. So that's the dura, and we have to go to the sinus, frontal sinus. So what we do generally here is we remove the mucosa, we use some Surgicel with iodine solution, and we seal it with bone wax in order to avoid some CSF leak in case we rupture the dura. So now we are going to the supraorbital canal. You can see the supraorbital nerve there. It's important to try to respect it, at least anatomically, to have a good functional result. And we drill the roof of the orbit. So this is the superior aspect. We cover this with a spongostan, and we just use our plastia in order to get this nice result. So let's go to another practical case, and let's move a little bit more posteriorly and laterally. So this is a patient, 47 years old patient, who was having some proptosis and eye pain. So we have a cavernous hemangioma located in the lateral aspect of this left orbit. So in these cases, we don't need to do a craniotomy. Maybe we can just do a lateral orbitotomy. And this is the beauty of understanding these bony chambers. With this lateral orbitotomy, going through the frontal bone, the zygomatic bone, and partially drilling a little bit the sphenoid wing, we will have enough exposure. But before doing our skin incision, it's important not only to understand these bony landmarks, but also these branches, small branches of the facial nerve, the frontal branches of the facial nerve, which should be dissected. And there is a good landmark, 2.5 centimeters posteriorly and laterally to the external canthus. That's the limit of our skin incision. In this case, we are preparing the field for this lateral orbitotomy. So this is the orbital rim, lateral orbital rim, and we dissect the temporalis muscle a little bit in order to perform our keyhole. So we are drilling it. We communicate the extracranial space with the intraorbital space, and with this small craniotomy, orbitotomy, lateral orbitotomy, we can drill the sphenoid, the most anterior aspect of the sphenoid, and we will have space enough. Once we open the periorbit, we will dive into the so-called yellow sea, and here it's very important, and I have learned this from the ophthalmologists, always perform blunt dissection inside the orbit. Try to avoid cuts and heat. So it's ideal to do this in the cadaveric specimens before going to the surgical theater in order to understand the relationships of the structures we can find. So this is the lateral orbitotomy. We open the periorbit, and this is the optic nerve seen in between the superior and lateral rectus muscles. If we remove all the fat inside the periorbit, we can see the globe, the optic nerve, and how we can check and arrive to this area in between the superior rectus and lateral rectus muscles. Here we do have the frontal branch of the supraorbitary nerve right there. And here we do have some ciliary nerves which are coming from the superior orbital fissure, as we will see later on. So let's come back to the real practice case. Here we have the optic nerve, and just lateral to it, you can see it's in between the superior rectus and the lateral rectus, we will have directly this cavernous hemangioma. So blunt dissection, try to avoid cutting or bipolar. This is the cavernous hemangioma. We try to delimit this lesion, and once we are sure that the lesion is completely isolated, we can even use the bipolar to shrink it a little bit, but making sure that we are not damaging any possible nerve. So that was the cavernous hemangioma. We decompress the optic nerve, and then we can replace our lateral orbitotomy. So understanding not only the bony landmarks, but also the muscles is very important. You can see how we are working in between these muscles. And we do have 7 muscles. We do have the superior oblique, which is right there in the trochlea. You can see how it's being articulated. We do have the inferior oblique, which is the only one not attached to the annulus of Sinn, as we will see later on. superior rectus and elevator palpebra, which are in the superior part in relation with the frontal bone, inferior rectus, lateral rectus, and medial rectus. So these muscles will delimit our windows inside the periorbit. This is the third practical case, 81-year-old man who came completely blind with this terrible proptosis. And here we do have a tumor which is growing in the medial aspect, in the superomedial aspect of the right orbit. So this tumor is growing mostly here. So we cannot do a lateral orbitotomy, it's gonna be too far away. And in this case, we will need a craniotomy and a superior orbitotomy, so-called supraorbital orbitotomy. So this is why we need to do a frontal craniotomy, and then we will drill the roof of the orbit and cover the periorbit. And once we remove the fat, this is the view we will have in our anatomical specimen. So the tumor is mainly growing in this superomedial aspect. So in this case, we will better go through in between the superior and medial rectus. This is the window in which we will be working. We can also work in this area, but the tumor is mainly growing in the medial aspect. So let's explore the specimen in the superolateral corner. So here we do have the lateral rectus, superior rectus, and we are going deep in order to find the optic nerve. But this is not the window which we will need in this case, we will need the medial one. So the medial one, we will work in between the superior rectus and the medial rectus. This is the anatomy we should be aware of. And here it's important to try to respect the trochlear nerve, which is going directly to the superior oblique muscle. So let's go to have a look at the intraop view. Once we open the periorbit, here we do have the superior rectus muscle. Here we do have the medial rectus muscle and how the tumor is growing in between them. And we can see after removing the tumor how the muscles are completely relaxed. Moving posteriorly, things become more complex because all these structures are going together in this narrow space, which is the so-called orbit apex, where we do have the annulus of Sinn and two important structures I will discuss later on. So the annulus of Sinn, it's mainly inserted at the anterior aspect of the sphenoid, and it means a condensation of the orbit apex periorbit and the intracranial periosteal dura. So all these attachments are gonna create this annulus of Sinn, where all the muscles except the inferior oblique are gonna be attached. Let's go to this fourth practical case. This is a cavernous hemangioma, again in the orbit apex, and in this case we need to reach this posterior area. And in my hands, it's much better to do a craniotomy, although I'm sure that many colleagues and some ophthalmologists will be able to take it out with a lateral orbitotomy. But this is the anatomy, anyway, we must be aware of. How all these neurovascular structures are joining together in this very narrow space. If we remove the fat, we will see the superior orbital fissure and the optic canal, and how the optic strut is in between these two structures. Right here, I remove the anterior clinoid, so we can see the optic strut, superior orbital fissure, and the optic canal. So let's have a look at the orbit apex once we remove the fat, and we will see the lateral rectus, superior rectus, and here we do have the superior and inferior branches of the oculomotor nerve, which are in close relationship with this tumor here. So this is the anatomy we should be aware of. What are we doing? We are drilling the superior aspect of the orbit. We will uncover it, and also the lateral aspect after doing a frontal craniotomy. Then we open the periorbit in this superolateral part, and first thing we will find is the optic nerve, because this hemangioma was growing medial to it. You saw that branch that was a superior part of the oculomotor nerve. We are opening now the nerve sheath in order to release some pressure during our maneuvers, and we are going inferomedially where we do have our cavernous hemangioma. So this is the cavernous hemangioma, and just behind it, we will find the inferior branch of the oculomotor nerve. Same thing, no bipolar, especially here. Here we have the oculomotor nerve completely compressed and in close relationship with this hemangioma. And so once we are sure that the hemangioma is completely disconnected from these structures, we can take it out. But always very important to try to avoid micro scissors and bipolar. So once we remove it, the nerves will get completely relaxed. And unfortunately, this patient was blind. He never recovered. He can see some lights, but at least he has not this uncomfortable pain that this tumor was causing, and he has a very good cosmetic result. So let's go to the last part of the talk, the orbit apex, and this is a pyramid of Caffrey. It has not chimneys, but I created these two chimneys because it's important to understand that in the orbit apex, the pyramid of apex, we do have two chimneys, optic canal and the superior orbital fissure. And we can have tumors which can grow through this to the intracranial space or from the intracranial space inside the orbit, like sphenoorbital meningiomas through the superior orbital fissure or optic sheath meningiomas through the optic canal. Let's go to the optic sheath meningiomas, which are growing like this one, especially and specifically inside the orbit. So we want to completely disconnect this optic nerve inside, and we will also decide to disconnect it from the chiasm in order to prevent the extension of this tumor intracranially. So we do a craniotomy. This is the keyhole communicating the orbit with the anterior fossa. So here we do have the sphenoid wing. We do the pterional craniotomy, and then we start drilling the lateral and superior aspects of the orbit. We want to reach the optic canal and to unroof it extradurally. Lateral aspect of the orbit, we are reaching the orbit apex extradurally, and this is the optic canal. That's the roof. So we are unroofing the optic nerve right here. Here we do have the optic nerve in the optic canal. So once we have reached that area, we just open the periorbit and we want to completely disconnect this optic nerve. So this is the optic nerve completely insufflated due to this meningioma growing, and we want to go anteriorly to reach the eyeball, which is right there. And we have to ligate it in order to prevent CSF leak. We cut it, and then we move posteriorly as much as we can to make sure that we are completely removing the tumor. And again, we ligate it, cut it, and remove it. Then we will open the dura because we want to prevent any possible extension. This patient was completely blind before surgery. She was misdiagnosed by a optic neuritis for 2 years, unfortunately. But we cut it, this part, intracranial part of the optic nerve, and luckily there was no tumor there. So we disconnected completely the optic nerve. We only left a small part of the nerve in the optic canal, but we made sure that this part of the nerve we removed was free of tumor and also the intracranial part of it. Superior orbital fissure, this is the last chimney we have to discuss, and it's a very important structure which is located in between the orbit apex intraorbitally and the anterior cavernous sinus intracranially. So it's a narrow space through which all the nerves of the cavernous sinus are crossing inside the orbit. And there are also some guests inside. Whenever we have an sphenoorbital meningioma, these tumors can grow through the superior orbital fissure. So in the superior orbital fissure, something is important is to understand that the annulus of Sin is limiting the superior orbital fissure in a lateral, central, and inferior aspect. And there are some structures crossing only through this central aspect, and these are the optic nerve, the ophthalmic artery, and the superior and inferior divisions of the oculomotor nerve, as well as the abducens and nasociliary nerve. So let's go to this case. You can see how this tumor is growing. The patient was having some visual problems and some pain. So we decided to do, in this case, a frontal orbitozygomatic craniotomy. And this is the only indication in my hands for this approach, because during the approach, as Professor Benes has always claimed, we are removing already the tumor. So how can we do it in a safe way? This is the superior orbital fissure. We must prevent damage of all these nerves. So what we will do, we will identify this interdural space because the tumor is growing like this. We will cut it. Here we will drill the lateral wall of the orbit, open this interdural space, and then we can have a safe surgery inside the orbit and inside the intracranial space. Sorry. This is the last slide. So what we are doing now, I do it in 2 or 3 pieces, this frontal orbitozygomatic approach, never in one piece. I think it's nonsense. So we are drilling the lateral wall of the orbit, and we are already removing the tumor during this drilling. You can see how the dura in the meningoorbital band, which is right here, it's quite sick because the tumor is there. It's just growing in between these layers. So we are doing the peeling in the lateral aspect of the cavernous sinus, and now we are unroofing the orbit. This is the superior part of the orbit, the roof of the orbit, and now we are moving to the lateral wall because we want to connect the intracranial space and the orbit through the superior orbital fissure, which is the narrow space through which this tumor is growing. Once we have exposed and have done our lateral orbitotomy, we will have a space enough to deal with this sphenoorbital meningioma. So we are opening the periorbit. And now we will drill a little bit more the sphenoid in order to open safely the dura in this more anterior aspect. We remove the tumor in the intracranial space. And once the tumor and the dura are removed, we move to the orbit. So we open the periorbit, and we were lucky this tumor was growing lateral to the lateral rectus muscle, which is the most common thing. So we can take it out, and probably we left a small piece at the level of the annulus of sin, but this is not the problem because we want to have a good cosmetic and functional result in this case. But luckily, it looks like we didn't leave too much tumor in it. So this is the result. We want to communicate the orbit with the intracranial space. So just to conclude, it's important to go to the lab to study all the structures that are in this narrow space to identify the yellow C and to avoid a red C. And the best way to avoid the red C is to perform blunt dissections, no scissors, and then we will not need bipolar. It's important, very important to understand how we can access the orbit. So this is why we have to master the bony chamber to understand the walls, the roof, the floor, and their close relationships to the different intraorbital areas and the intrinsic structures on them. And finally, we will be able, with all this knowledge, to decide if we want to do a single orbitotomy or we will need a craniotomy plus an orbitotomy. Thank you so much.
Thank you, Pablo, for this marvelous presentation, bridging the gap between neuroanatomy textbook and the clinical applications. There were two questions. I think one of them you answered it. What the application of frontal orbital zygomatic, and you have mentioned it, one of the question. And the other question, how you can save the ophthalmic vein. That's another question.
So, ophthalmic vein, say again, what's?
He said the ophthalmic vein in the orbit. I think somebody threw this question.
Generally, the superior ophthalmic vein is crossing the superior orbital fissure because it's communicating the fascial veins to the cavernous sinus, and it's crossing the most lateral, superolateral aspect of the superior orbital fissure. So it's outside the annulus of sin. And the inferior orbital vein is crossing through the inferior orbital fissure to the ptericopalatine fossa. That was the question, I guess.
Yes. Thank you very much.
If I can make a comment, whatever looks like a vein, don't buzz it.
Yeah. I think the message was well documented. Don't use bipolar in the orbit in general, because these nerves, they are very sensitive. Yeah, I agree. Well, there is one senior guy who is trying to connect, and I think we were waiting for Pablo to help him.
I will take care of him. Who is him?
Professor Subaih from Jordan. He is a senior colleague, and he is very keen to join us, and he has expertise as well. All right. So we'll move for the next speaker, will be Professor Anil Nanda. Anil, are you with us?
Yes, I'm here. I'm just trying to get my screen going here.
Oh, all right. Anil Nanda, he's from Puga University Hospital in New Jersey, close friend and expertise in the skull-base surgery. He's going to share his expertise in with always the twist and flavor of presentation that we all used on Professor Anil about frontal meningioma.
Well, thank you so much. Can you guys hear me? Is it clear?
It's clear.
Okay, perfect. So thank you again for this opportunity. It's always difficult to follow like Pablo Picasso. I'm like, this is a great painter. Pablo has a great name. So I'm going to go on to the anterior cranial base. So I think from the very fine part of the orbit, I'm going to go into these large anterior cranial base meningiomas, olfactory groove, and diaphragm sellae. So I want to thank the leadership of Vladimir and Imad for doing this. This is a great service. And as you can see, there's a couple of hundred people watching. So this is a great tribute to global education, which is what we all need during this time. So I just want to tell you, we live in the midst of a big crisis, having lived in New Jersey. And you can see now there's over 9 million cases of corona with about 500,000 deaths. So I think in this time, we must always remember the colleagues we've lost. So, Jim Goodrich and the first female neurosurgeon of Indonesia, Lou Ziming from China, Crespi, and Pereira from India, who all died of corona. So again, we must remember our colleagues for the great service they've done. And as you realize, it's had a big impact that most of the national meetings, the WFNS, CNS, Senior Society have been canceled. Our global neurosurgery meeting, which is now going to be virtual, and invite all of you September 11th and 12th to speak there. And I think there's been a big paradigm shift with Corona. I think we're wearing masks, we're social distancing, and we're doing these great virtual meetings. So the globe is coming together, which is good. So this is my personal series about, 17,000 surgeries with about 700 cranial-based meningiomas. So I thought I'll just get down to the anatomy. Since this is anatomy, I think the anterior cranial base is the most important thing is devascularization of these large tumors. And I think near the olfactory bulb, the ethmoidal arteries can be very pesky. I am not a big fan of embolization of these tumors. I like to go and get them while I'm there. And I will tell you, after we've gone from the orbit where you don't use the bovie or the bipolar, on the anterior cranial base, I will sometimes use a bovie just because the bleeders can be very pesky. Just to show you the cranial base of the frontal bone, the sphenoid bone, the ethmoid bone, this anatomy, and then just to look anteriorly when you look at the sinuses, the optic sheath, and this is a sort of a sagittal view showing the chiasm and the crista galli. And I think that to remember this anatomy is very important right here, especially when we're coming from the front. And you can see here the gyrus rectus and stuff. So when you look at all anterior cranial based meningiomas, you can see they come largely from the ethmoidal area, frontal sinus, sphenoid sinus, and they normally present. So I have about 180 cranial based meningiomas, and you realize these are largely female. It's always good to recount history, and the first anterior cranial based meningioma was removed by Francesco Durante from La Sapienza. I know Giovanni Brogi you can look at the history. This is really the seminal case from Italy, global wide, with a long-term survival, was published in Lancet, and we always need to acknowledge our debt. So when you have large anterior based meningiomas, obviously these cannot be removed endoscopically. And people will say, oh, you need orbitozygomatic, you need this, you need that. My approach is when you have such a large tumor, once you debulk the tumor, you get all the space in the world. So I think, devascularization is important. So here's somebody that was institutionalized with sort of dementia, and somebody decided, oh, maybe we should get a scan. And you can see this is almost a 14 centimeter meningioma arising from the cranial base. And I tend to do everything unilaterally. So this is the one thing I want to talk about, trials and trepidations. I don't like to touch the opposite frontal lobe. So on this instance, I went from one side and from the left side and devascularized and pulled the other side out completely. You can see she did very well and actually went back home with no problems at all. So when you have tumors this large, I think, for olfactory group, in terms of the anatomy, some purists would say, oh no, we go bicoronal and we go subfrontal. On this case, if you can see, I went from one side and then I divided the falx and then removed the rest of the falx, but didn't touch the opposite frontal lobe at all. So this is the view intraoperatively from one side. Here we put some glue there just to prevent leak. Sometimes put some pericranial flap in there. Because a CSF leak is a big issue. And as you can see, this patient lost 50 pounds. So I tell people, instead of having your stomach stapled for weight loss, you can have a skull-based tumor removed and you'll do very well. So this is the large tumor there. Again, same tumors like this. We go from one side. I tend to split the fissure if they go out too laterally. Otherwise, I will avoid that. Just go pure supraorbital from the front. It's our angle coming in this way, devascularizing the tumor. So what approaches have we used for these? We've done orbitozygomatic, terional. I did initially in my career, I would do bifrontal, extended subfrontal, which I'll talk about it, but I don't do those. I rarely do those now. So since I moved to New Jersey, I didn't think I would see large tumors in New Jersey. I thought that would be largely in Louisiana. But here's somebody that had large cognitive issues, and you can see this was a very large tumor that came from the anterior cranial base. So here what I did is I came from the bottom, devascularized it, but then I also made a small cortical incision and got this part out. So I debulked all this to the cortical incision from the front and then came from the bottom, but I didn't go to the opposite side at all. And you can see we had a very good result, and she's actually done very well cognitively. So she's had no issues at all. Similar cases I just did a month ago, large tumor, atypical, grade 2. Now with the classification of meningiomas being a little more expanded for grade 2s, a lot of these are coming back as grade 2. It's almost 30% when they used to be 10%. And my worry is that maybe we are radiating these too much. I'm a little more cautious, but some of the radiation therapists and neurosurgeons say, well, it's grade 2, you got to radiate it. I tend to be away from it. So you can see this. I also feel that they need to recover cognitively. Again, fibrous meningioma. This is an older lady, 80-year-old. And again, we just went unilaterally. The teaching point for the residents and the younger people in the audience is you want to go from that side and devascularize the base. That's really very important. So you can see the base here, completely devascularized. Once you devascularize the base and go across, then it really is like a convexity meningioma, because you devascularize, you pop it out, and with the CUSA, it really helps out. Same thing with this is a hemangiopericytoma. This was extremely vascular that we operated on. And people would say, well, why didn't you embolize it? And perhaps we should have. I am just not that big of a fan. It's an extra procedure. I've seen some complications sometimes. So unless I feel that the big feeder, or, like say for AVMs, I use it a lot. So I tend to tailor it to what I need. Now we'll talk a little bit about the extended frontal approach. We used to do this. I rarely do this now, but we published this paper with Shaker. You can see this. We take the whole orbital rim out. It was a beautiful technical and anatomical exercise because you really dismantle the face with the incision. But the indications aren't that great. You can see we used to put a big pericranial fab, and I think it's important to learn how to do this because you might need it for trauma, for something else. And I think it's important for the younger people to know, it's like basilar tip aneurysms. We don't clip them that much anymore, but you need to know the anatomy really well. So here you can see we come from the side, and you can have a big pericranial flap, and all this gets dismantled. And we would actually do this approach even going down to the clivus for clivus chordomas. So now it's more of historical interest because you can go endoscopically. So it's sort of a good way to look at that. Again, similar issue, and again, I want to show for the younger residents and stuff, you can get all these cases unilaterally. You don't need to go to the other side. And I always feel, I'll go over that a little bit, you can have cognitive problems with that. Just to show you this case, I hope this video works. So you can see here, we have devascularized, we're devascularizing the base. I don't know why this is not working. The video is not working. Yeah, here it is. Okay. So here it is, and I like to, so here it is. So I'm really bipolaring the base very well. And unlike the orbit that you heard of, this is not pretty surgery. When you have like a grapefruit inside the brain, you want to move quickly, you want to debulk. It's not like you want to bipolar every red blood cell you see. Okay, here speed is important because I think that can add to morbidity. Obviously, you should know when to slow down and when to go fast. So here we are debulking the tumor. We've devascularized it. And obviously, this is a large lesion. And you see this big pumper, see that pumper right there? You can get really bad pumpers coming from the ethmoidal. And sometimes I will use the Bowie on top of that to clear it. Here you can see you're across the entire side. You can see the optic nerve there. Obviously, if it's a soft tumor, it's easy. If it's fibrous, it's going to be a little more trouble. Right across the base, and you have a very good outcome with that, just to show you the post-op. Another case like that. I'm not getting my videos here. Here, let me try this. Again, very important bipolaring here. Again, I know the earlier talk was don't use the Bowie. Here, I think it's so important to get that base completely devascularized. So my technical steps anatomically are devascularize from one side completely, use the CUSA, don't touch the opposite frontal lobe, and you can get a really good dissection like that. And I think the CUSA really helps. But here you can see it's a fairly fibrous tumor. and you peel this backwards. And another example like that. But again, I tend to go from one side only and have fairly, decent result. This is something I just did recently, again, a month ago. Large tumor, you can see it goes down near the sella there. Now, for the point of debate, and I'll talk about this a little bit later, in terms of getting down to coming from from an endoscopic approach, these large tumors, unless it's somebody really old, I really don't agree with doing that. It doesn't really help that much. Now, we looked at all our olfactory glue meningiomas and looked at the changes that we see. So we looked at the contralateral lobe to see if it got affected and radiologically. So we looked at all these patients, about 57 of them, and we looked at the comparison, and you can see here, we looked at the changes between a bifrontal and a one-sided approach, whether there was changes in the contralateral frontal lobe. Now, we didn't do neuropsychological testing to say, listen, there's some cognitive issue, but based on radiological things, and this was shown by other authors as well, that there was clear difference if we went unilaterally. So we published this. These were 57 patients, and most of these were large tumors. 75% were larger than 5 centimeters. And when we compared the changes, it was significant. Now I'll move quickly to tuberculum cellae meningiomas. These were smaller meningiomas that we included, and we went terional. If you look at these, the history of these meningiomas, again, Holmes and Sargent described things like the Foster-Kennedy syndrome. You can see that. And then there's a classification for diaphragm cellae meningiomas, a type A, type B, and a type C. We published this in our series. And you can see here, we look at which way the optic chiasm is draped and how we remove this. And I think that's very important with the anterior cerebrals. And I think you could argue that some of these cases could be removed endoscopically, but I feel if they go laterally, you can see here a nice resection coming from the side there, with a good result. And here now we did show we had worsening of vision. People say, we're talking about complications. There's clear-cut complications. Any small vessel can cause visual loss, so you need to be very cautious on that. So here's somebody, I'll show you a clinoidal meningioma that you cannot take out endoscopically. I split the fissure, and here it is. You can see we're devascularizing the tumor. I really don't like to touch the optic nerve at all. So you'll see this towards the end. Bipolaring the base, removing more tumor. And the CUSA really saves you a lot of time. The fissure is split, and you can see here. And once you'll see, let me just move it up. So you can see here, we peel this off. Here you can see the internal carotid, anterior cerebral, and you notice we're peeling this off the optic nerve there. You'll see the optic nerve in a minute. There's the optic nerve completely, and very, very careful. There's the internal carotid, MCA, anterior cerebral with a complete resection. And this patient, actually, the vision got better. So in significant cases, we see vision removed. So I think in medicine, you'll always see a change occurs, okay? Your cheese gets moved, and this is the famous painting from London, the Fighting Temeraire. And you can see the Battle of Trafalgar, that ship was very useful, and then finally a little steamship was pulling it away. So it was a change that happened, and I think endoscopic, I did it, endoscopic transsphenoidal yesterday. It's a great technology, and it's important to figure out where its use should be. So if you look at the meta-analysis, this was from ENT surgeons, and their feeling was that even for pituitary surgery, the outcomes were better. And so I think for tuberculum cellae meningiomas, the CSF leaks are still a little bit higher, but my feeling is it's technique that's important. That I think, and we have to talk about our complications. This just shows you a meta-analysis of these tumors that were removed, and again, a quality of life thing. Now, I will tell you that here's a case that I did several years ago. I thought this was a meningioma. We took the whole thing out. This turned out to be a chordoma. So sometimes pathology can dictate what you do, and this was a long-term follow-up with no recurrence, yeah. I think we looked at all our Simpson gratings for tumors, and we published this, and we felt the Simpson grading was relevant. And there's, you know, the UCSF group, several groups have come forward and said, this is not valid anymore, or it's not important. And we find that even for skull-based tumors and for regular convexity meningioma, Simpson grading is very important. So just to show you in our paper where we looked at all meningiomas, paracellular, convexity, skull-based, and you know, this is mainly aimed at the younger members of the audience. You know, why you take an academic life. So I published this paper, and we published it in 2016. And a month later, we get a letter from Dr. Simpson saying, "You want to congratulate us for the paper." You know, he says, "I'm 89 years old and frail health with coronary artery disease. I know you're going to give a talk in Melbourne later this year. I won't be there. But, you know, this is why we do academics. This is one of my most prized possessions. Here it is, a letter from the Dr. Simpson. Unfortunately, he passed away, but what a great man. And we all learned from him. And I think that Simpson classification is still very relevant. This is what we showed with skull-based meningioma. So I wish I could tell you everybody does well. This is the legend of Gilgamesh, that if you know, when he talks to the code of Hammurabi, if somebody has a complication, they treat with a metal knife to cause the man to get his hand cut off. So this way, all surgeons wouldn't have hands because we've all had mortalities. Our visual outcome, we definitely had deterioration. 10% of our cases, large tumors, we had visual problems. And the same with CSF leaks. Our CSF leaks were really low. We only had 3, it was like a 1.6% out of 180 cases. So not that high, but I think endoscopic surgery is important, it's safe. And I would sort of end by talking about all skull-based meningiomas. I think this is something I've felt very dearly about in terms of the whole gamut. And I think for the residents, I think you know, you want to do the right thing, but you always not want to have a sense of ambiguity too. I think this is Edward Hopper. They call him the patron saint of solitude, the great American painter. This is Nighthawk when he talks about narrative ambiguity. And it's like the dean of the medical school. Half of what we teach you here is wrong. Unfortunately, we don't know which half. So as the younger generation comes forward, you will have, you know, better insights, newer technologies, and always doubt. I always tell people, always doubt. We'll say, oh, this looks great, patient does great, anterior-based meningioma is the only way to do it. No, there's always a better way, and we all need to improve. So my feeling with these meningiomas is that, you know, with anterior cranial base and foramen magnum, you can get a complete resection. Cavernous sinus, you can get a subtotal resection. And Simpson grading is important. I will end with Diogenes of Sinope. He would always have a lantern in Greece and he'd go looking for the truth. And I think the truth is very important to these skull-based tumors, that we be very honest with our complications and say, this is what we can do, these are our limitations, and that's how we'll improve. So I'll end with this social distancing, creation of Adam. This is the, and this is, I put this in for our friends from Milan. Giovanni, this is the wonderful painting of the Last Supper. This is with social distancing. And you can see the stages of quarantine. Hopefully we'll all be safe and the coronavirus will be conquered. And I think forums like this bring all of us together. You know, I think in the end, we are one big family, and it's you know, hopefully we'll all get through this. And Franco was with one of our meetings, and he said very beautifully, they said the virus was spreading through China, it was because of Wuhan. They said the virus spread through Italy because of the elderly. In the end, the virus comes for everybody. So I think it defines, you know, it's something that unites us and reminds us no matter who we are, we all have the same, you know, same genetic, all our mothers love us the same. And this is the rainbow over New York City at the height of the epidemic. And I thought this was a sign from God that we would get through. And with the grace of God, we all got through. So I wish all of you safety, and please be safe. And I'm open to any questions. And again, I want to invite all of you for our Global Neurosurgery meeting. Will be September 10th and 11th and 12th. We have a generous grant, and we have made it free for all the residents and medical students across the globe. So you're all welcome to join. And we have a star cast on this. So Michael Mormont, who's an expert on healthcare and inequalities, will be speaking. He's our landmark, our speaker. Thank you. I'm open for questions.
Thank you, Anil. I have to add some comment. I'm happy that I'm following the same things for the unilateral approach. I think bifrontal approach is historical in these cases. We inherited from the pediatric neurosurgery. And the important things, I think, we don't deal with the frontal sinus, we don't deal with the venous system between the frontal lobes and the superior sagittal. And the most important, the devascularization. You mentioned step 1 in resection of a meningioma that make it collapse. And an important factor that you see the vital structure early during the procedure. You are not coming from the dome to see the pericallosal artery or the optic nerve at the end of the procedure. You see it from the beginning and you protect it. There was one question, I think, from which side you prefer?
I always go from the right, but if most of the tumor is on the left side, then I'll go from the left. But otherwise, I go from the right. It's not my political leaning, it's just the non-dominant hemisphere.
Right. Wonderful to see you and to hear you as usual. And I move now to my colleague, Professor Thomas Santarius, to run the moderation of the next speakers. Tom.
Tom, please unmute yourself.
Unmute.
Please
sorry,
unmute
yes.
yourself. Yeah,
I'm
better.
muted now. In fact, Salman, you seem to be unmuted already. I think you had the next three presenters to present, but I suppose
I'll do it. It's fine, Thomas. No worries. It's my pleasure, really. This dear friend of mine, Roy Thomas Daniel, who's professor of neurosurgery in Lausanne. We have been working together in many projects, and he's a dear friend for ages. A lot of good work that he's done over there is spilled up, and we all are sharing all the juices that have come out of it. It's wonderful to have Roy Thomas Daniel with us, who's vice chair of neurosurgery at University Hospital Lausanne. Roy.
Thank you, Salman. It's great to see all of you, and thanks again to Imad and Vladimir for putting together this nice program. It's going to be a difficult act to follow, Professor Nanda, but keeping with the mandate of our committee, I'm sticking to essentially anatomy. I'll show you a few examples at the base, so there will not be any videos with large tumors. And anyway, you've all seen that with Professor Nanda's work. So my topic today is to describe the anatomy of the anterior clinoid process, and which I believe is the key that will help unlock the anterolateral skull base. So I've borrowed heavily from some of my friends, principally Christophe Destrou from Tours, a few Japanese friends, including Kenji Ohata. So this will have material from many sources, which I have cited below. So we need to look at the sphenoid body to put it into a scheme that's easier to understand. We start with the body of the sphenoid, which looks like a cube, and it's slightly flattened on one side. And you can see its historical relevance to the shape, why it's called the sella turcica. And there you have the dorsum sellae and the posterior clinoids. And this is the anterior part of the body of the sphenoid. You can see the two openings there, which drain the sinus, and there is the jugum. So then you have the two pterygoid processes, which are attached to the inferior part of the body, and there's the medial and lateral pterygoid processes. And then you have these projections, which are the anterior clinoid process. And there you can see the greater wing of the sphenoid. So there are two wings for the sphenoid. You have the lesser wing here and the greater wing. The greater wing is made in three planes. So you have the lower one, which is the infratemporal part of it, which is a horizontal plate, and that goes on to a temporal plate there, which is more vertical. And then you have the orbital plate, which is in the coronal plane, and it limits the middle cerebral fossa from the orbit. So I hope this makes it slightly easier to understand the anatomy of the sphenoid bone. And there you see the superior orbital fissure, which essentially lies between it's on the lateral side of the body, and it lies between the lesser and the greater wings of the sphenoid. Anteriorly, this bone articulates with the ethmoid, and it also drains. The ostia are covered by the ethmoid there. If you look at the bone from the front, you'll see this. You'll see the lesser and the greater wings here, and between the two wings you have the superior orbital fissure, and then you have the optic canal here, and that is the body of the sphenoid. Now this is a view from the top. So the anterior is here and the posterior is here, and there you see the clinoid process, the optic foramen here, the planum, the tuberculum, the chiasmatic sulcus. That's the lesser wing of the sphenoid, and these are the two orbits here. So this is a view from superior. And then this is an interesting view from posterior, and you're looking forwards. So those are the frontal bones there. You have the crista galli here, and that's the clinoid process, the bone that we are going to talk about today. And there you see in a little oblique projection, you can see the optic canal and the superior orbital fissure. Now, if you magnify it and turn it a little bit, it shows you some interesting anatomy. So this side, that's the lesser wing of the sphenoid, and you can see the clinoid process. But look on the other side. You see this structure here, that's the optic strut. And essentially what it does is to separate the optic foramen from the superior orbital fissure. That foramen there is a foramen rotunda. So you look at it from superior, this is the bone that we're talking about. That's the clinoid process. And you see the rest of the sphenoid bone and the lesser wing of the sphenoid here. A close-up view of the clinoid process, you can see the parts of how the clinoid process is attached to the rest of the sphenoid. Essentially, it has an anterior root, and that anterior root forms the roof of the optic foramen. And the posterior root forms the lateral surface of the optic foramen, and the posterior root is the optic strut. And on the other side of this is the superior orbital fissure. If you look at it from the side, you can see the two lesser wings almost superimposed. That is, you can imagine it's something like the pedicle, and that is the optic strut, which attaches it to the body of the sphenoid. Now, what's interesting about this bone is that it's got a very intimate, this particular process has a very intimate relationship with the internal carotid artery. And you can see the siphon of the internal carotid artery. And as it comes here, it becomes the supraclinoid segment of the internal carotid artery. And you can see as if the clinoidal, anterior clinoid process actually marks the outer border of the carotid artery and keeps it in place, if you wish. Now, if you just turn the same specimen a little oblique, you will find the relationship from the medial side. You can see the carotid on the other side, and from this side, just to show you the intimate relationship of the clinoid process to the internal carotid artery. Now, this is a specimen that shows some of the anatomical variations, and this is very crucial for skull-based surgeons to understand, is we did describe the anterior clinoid process and the posterior clinoid process, but sometimes you can get what's called the middle clinoid process, and it's not that rare. It's about 36% of the human population. And sometimes you get a fibrous band or a calcified foramen here, which forms, and that really tethers the carotid artery. And so when you do a clinoidectomy, you need to know if you have a foramen here, which is a complete carotid foramen, if you wish. So it's fortunately only present in 5%, but we need to know if it is there while we are doing a clinoidectomy. And there you can see an incomplete foramen here and a complete foramen here. So these are different variants that can occur, and tells you why you need to look carefully at the CT scan before you decide to embark on these tumors. So again, you find a complete on both sides. So the various combinations can happen, and a CT scan should be carefully looked at. Now, when you do remove the clinoid process, you see these condensations of dura. The surface, the dura of the clinoid process kind of condenses to form the proximal and the distal dural ring of the carotid. So in between these two dural rings is what is called the clinoidal segment of the carotid. And this anatomy is crucial to understand, especially if you're going to clip the proximal aneurysms of the carotid, or if you're going in for clinoidal meningiomas, where you need to understand this anatomy carefully before the meningiomas are tackled. Let's say you do remove the clinoid process completely, And then you would, in this cadaver image, you can see its relationship. That's the proximal and the distal ring. And there you see the inside of the cavernous sinus and the ostia of the venous ostia into the cavernous sinus. So that's the entire cavernous segment that you see there of the carotid. So a little more zoomed image. So again, that's the second cranial nerve there. And there you see the distal and the proximal rings of the carotid, the clinoidal segment here. And there you can see the very close relationship of the ophthalmic artery. So when we are going towards cutting the dural ring, you need to pay careful attention to the ophthalmic artery. So these are the images that show you from the top that you can see from the endonasal side. So the whole advance of endonasal surgery has completely changed our lives, because now we understand the carotid from both sides. So for the last 15 years, our understanding of the artery and the nerves and the skull base have remarkably improved. And so this anatomy is now getting more and more very familiar to the neurosurgeon today. So that's the sphenoid sinus here. And you can see this was actually talked about yesterday, but quickly to recap on some important points. That's the pituitary fossa. And there you see the clival carotid, and it becomes the cavernous carotid there. And there you have to understand this particular segment has two, you have the clinoidal segment and also the cavernous segment, both in the same vertical plane. And there you can see the opening of the orbit here. In this particular cut, you can see the optic canal here. That's the optic nerve there. And this is an important anatomical landmark, which is the lateral opticocarotid recess. So these are the anatomy from the endonasal perspective. Again, a few images that show the variations that can occur. So that's the optic nerves there. The carotid is here. Again, a very prominent lateral opticocarotid recess. Again, you can see the removal of the bone covering the carotid. Here, the opticocarotid recess is not that prominent. So various variations can occur. This is an intra-op view. So you see the opticocarotid recess here, the right optic nerve, the pituitary fossa here, the carotid prominence. So that's your lateral opticocarotid recess. Some important concepts of correlation and between the endonasal perspective, which you can see here, and the endocranial perspective. So the important structures to realize is this is the carotid, and it has two rings, and you saw the rings from the endocranial perspective. The distal ring is what you see here, and this is where the proximal ring is. And these two rings kind of converge, and they almost meet at the medial opticocarotid recess. And this particular specimen, you have a very prominent lateral opticocarotid recess. And what you need to understand is that the lateral opticocarotid recess is what you see as the optic strut. So that's the correlate of the optic strut. So if you keep following this, what you're doing is you're removing the optic strut, for instance. And the medial opticocarotid recess corresponds to the middle clinoid process. So these two points are an important perspective to realize, and that tells you exactly where the distal dural ring is and the proximal dural ring is. So essentially, this is the segment of the carotid, which is the clinoidal segment, and everything inferior to that is the cavernous segment. And they both kind of almost join at the medial opticocarotid recess. So after this is supraclinoid carotid, and which is essentially the ophthalmic segment of the carotid artery. So this is the important slide in this whole presentation, actually, a kind of correlation between endonasal and the endocranial surfaces. So from an anterior view, you can just a quick revision. This is the optic canal, and this is the superior orbital fissure in the coronal plane. And the superior orbital fissure, this is common knowledge. These are the structures that go through it, the V1, the 3, 4, and 6, and the ophthalmic vein. Pablo took you through this anatomy, so I'm not going to go through that again. But just a few studies that describe the superior orbital fissure. I don't think Pablo put this into his presentation, so I included this. This is a very good study that analyzed over a large series of CT scans to look at the variations in the morphology of the superior orbital fissure. So they kind of divide it into two groups. Essentially, type A is when you have a very long fissure as opposed to a shorter fissure, which is type B. And the type A has a kind of constriction here. So it's divided into essentially two segments. And then you have a longer thin segment. Most of the neurovascular structures are in this region. So it is essential to know this, this anatomy before doing a clinoidectomy. And it's important to look at it in a CT scan. So these are some measurements. There's no need to memorize these things, but the two measurements that are useful is this C, which shows you the length of the superior orbital fissure. And that is varies between type A. Type A is one which you have a very long fissure and the other one which is a shorter one. The other important is the width of the fissure, and that's this D here. So the distance from the optic nerve to the end of the fissure. So that also is different between the two types. So this anatomy should, no need to memorize it, but you need to look at this anatomy to kind of decide how difficult or how easy or how to do the peeling of the lateral wall of the cavernous sinus and how to see the clinoid. Another important paper that came out is about the anatomical variations in the pneumatization of the anterior clinoid process. So you saw a few pictures which I showed in which the anterior clinoid process was well pneumatized and the strut was almost full of air. So here you can see that's the type A. So the pneumatization is through the optic strut. And you can have pneumatizations through the anterior root, as you see here, and pneumatizations through both, in which the optic nerve will be kind of floating inside a large sphenoid sinus. And if you correlate, the most common variant is the clinoid process being pneumatized through the sphenoid sinus, and via the optic strut is the most common. So the cranial dural matter, especially for the younger people who are attending this, is two layers, and we need to know that there is an outside layer, which is the periosteal layer, and the other one is the dura propria, which is the cerebral layer. So that's an important concept. And as you can see, that it follows the bony anatomy, and then in some areas they kind of diverge, and those are the interesting ones. So when these two layers don't fuse, what you have in between in adulthood is the venous sinuses or fat, as in the orbit. So if these two layers are not together, then there's something that can disturb your surgery between the two. So just to look at the clinoid process and its attachments. So basically, there are two petroclinoid folds which get attached to the anterior clinoid and the posterior clinoid. And let's draw these folds. So they originate from the clinoid process and go posteriorly. So that's the first one. That's the anterior petroclinoid fold. So this is only one half of the specimen. That's where the diaphragm ocella is, and this is lateral. So this is the middle fossa. So that's your anterior petroclinoid fold, and essentially posteriorly it corresponds to the free edge of the tentorium. And then you have the posterior petroclinoid fold, which is the superomedial edge. It continues as the superomedial edge of the petrous bone. So these two petroclinoid folds divide this region into four sectors. So you have the anteromedial sector, which is essentially the roof of the cavernous sinus and the pituitary fossa. So how did that form? And like I told you before, you have an interdural space, and that interdural space is full of blood. And in infants, of course, you have bigger ones, and as you grow older, in adulthood, the persistence of that will lead to sinuses. So you have some interesting structures inside that. So I mean, this is not really embryology, but you could look at it as it is. So these two folds is what we are talking about. When they fuse together, they form the diaphragm ocella here, and you have the large carotid artery, and the contents of the cavernous sinus is essentially venous channels. So this understanding is crucial when we deal with this region. Okay, so that's the roof of the cavernous sinus that is zoomed up a bit, and so that's your diaphragm ocella. So you have the oculomotor trigon there, the optic nerve that's cut here to show the dural relationships. And then you have the posteromedial compartment, which is basically it can contain a lot of venous spaces. Essentially here it's the basilar venous plexus. And then the lateral compartment, anterolateral compartment, is the lateral wall of cavernous sinus in the middle cerebral fossa. So in that compartment, that's important to understand because the fifth nerve is located like a three-finger pouch, and an intimate understanding of this three fingers is important to peel off to see the true cavernous membrane and the structures inside the lateral wall of the cavernous sinus. So these, when you do the peeling, this is what it will look like. You will see the various cranial nerves in the lateral wall of the sinus, the third, the fourth, the V1, V2, and V3. So from a lateral view, this is what you will see. You have the third nerve, the fourth nerve, the V1 here, and these are the structures that reach the superior orbital fissure. And this is the line that demarcates vaguely the boundary of the cavernous sinus. So below that, V2 and V3 are technically not in the cavernous sinus, and they go out through the rotundum and the ovale. So this is a lateral view that shows the same. So another view that shows you with the clinoidectomy here, and this is the clinoidal segment here, and then the entire peeling is done. This is all the structures that you would see, the third, the fourth, the V1, V2, V3 forming the ganglion here. And this cut that shows you the tentorial edge. So when we do operate in this region, the patient is usually positioned like this, the head turned to the contralateral side. And depending on how much you want to do the transcavernous or how much of the cavernous sinus surgery you want to do, the incision could be modified. And this is Kenji's book, Kuba's book actually, and which shows the venous the anatomy of the region and shows you why it's so important to know in what plane to elevate the skin flap so that you don't damage the branches of the facial nerve. Generally, what we do is a one-layer scalp and temporalis elevation. We plan for an orbital osteotomy. The temporalis is taken inferiorly, and there you can see the anatomy of the deep temporal and superficial deep temporal fascia, all of which are important to preserve the frontal branch. And that's the exposure you need. That's the zygomatic process. A small opening here, a burr hole can be done or drilled out like a club head. And then a craniotomy is done that Pablo mentioned it. I never do a single piece. I think it's a dangerous way to do things. A two-piece allows you to keep all dural structures intact. So when you do a craniotomy in this region, a very basal frontotemporal craniotomy allows you to access the skull base, and then if necessary, an orbital unroofing is also done. It gives you extra space to work in. And once you can preserve that whole, you should preserve that whole piece, which can be reattached to avoid cosmetic problems. And once that's removed, you see the orbit, you see the temporal lobe here, the frontal lobe there. And then what we do is what's called the sagittal unlocking. So you're spreading the frontal and temporal lobes away to get to the center of the brain on one side. And then you see the meningio-orbital band, which forms the key. And once you see the meningio-orbital band, it is cut. And then, of course, you can do the mini peeling. If you want an entire transcavernous approach, then you need to expose all of them. But essentially, you need to do enough to remove the anterior clinoidal process. You can't pull it out without a full vision. So whatever peeling is necessary that shows you the entire clinoid process is good enough to start with. But then if you need transcavernous access, then you need to do the whole thing. So some key steps for extradural clinoidectomy, that's a superior view. So the lesser sphenoid wing is resected to disconnect the lateral connection. And then the roof of the medial root, which is the roof of the anterior of the optic foramen, is unroofed to disconnect the anterior and the medial connection. And then, of course, you have to core out the inside of the anterior clinoid process, and then the edges can be fractured in and the tip of the clinoid is removed, provided it's not attached to a middle clinoid process. So that's why you need to study the images properly before. And then to complete the optic nerve decompression and access, and to allow the optic nerve to be moved, the rest of the optic strut is removed. But of course, remember that it leads to the sphenoid sinus. So we need to be sure that we don't make an opening, or if we make an opening, we need to repair it properly at the end of surgery. So that's your entire clinoidectomy. So just something about the peeling, just to show you the anatomy here. The optic nerve is here. That's the membrane that covers the carotid artery. You have the tip of the clinoid still seen here, the third nerve, the fourth, V1 and V2. So this is what the lateral wall of the cavernous sinus. And when you remove the membrane, you can see the C3 segment of the carotid artery. So just to give you quickly a few examples, this is one of the rare instances in which we have to do transcranial surgery for secreting pituitary tumors, and we need to be really aggressive to get good results. And why is that? Look at the criteria, and these our good friends, the endocrinologists, keep changing the criteria. So when we were training, we could get a cure in 72%, and then they just moved the goalpost in 2010, and the entire results went down to 54%. So this is the current results based on an analysis that we recently performed in a large group of patients. So look at this patient. He came with this pituitary adenoma, not very large, and going into the cavernous sinus. So we did the standard transsphenoidal approach, but we entered the cavernous sinus, went into the loop between the inside in the retrocarotid space to remove as much of the pituitary adenoma as possible. The IGF-1 did drop, and you can see the post-op image. You have the entire cellular compartment, and the medial part of the cavernous sinus is now free of tumor. But look at this, there is still some part in the lateral part of the cavernous sinus inside the clinoid. So where the clinoid should have been, there is now tumor. So, and it's so close to the optic nerve, there's no way you can hit it with radiosurgery of 30 grays. So these are some of the few indications when a transcranial surgery, even for small tumors, is necessary. So look at the transfer, you can see the hollowing out of the clinoid process, essentially by tumor here, and that's the part inside the clinoid, if you wish. A quick video to show you the surgery. Again, the same images here. The patient is positioned about with the head turned 20 degrees, and that's the meningioorbital band is cut. And you see the whole surface of the clinoidal process that has been exposed. You drill it safely, and then once you disconnect the optic strut, you see the clinoid process is free, and the clinoid process can then be removed. And then immediately you see the tumor. Once the clinoid is removed, you can see the tumor. Essentially, we are approaching this through the anteromedial triangle. So there you can get stimulation of the third nerve. The optic nerve is on this side, and that's the anteromedial triangle, Dolenz triangle. That's the tumor within that triangle, which can be removed off between the second nerve and the third. And that's a piece of fat that we put in just in case the IGF-1 was not good enough and there was no remission, and we could find a spot that we could give radiosurgery for inferiorly. Then we have now a fat that protects us. So another very common indication to do a clinoidectomy is clinoidal meningiomas. I'm not going to go into the details of this classification by Al-Mefti, and essentially divided into three groups. The group 1 is the bad one, and that's where the adventitia of the carotid artery is taken by the tumor. So it's very, very difficult to preserve, to remove the whole tumor without making a hole in the carotid, which is never advisable. So in group 2, of course, you have a good plane around the carotid artery, and very often you can get a total excision. And group 3 is the group of small tumors which enter the foramen. So they're optic foramen meningiomas recently. So we did a large, we combined our case series with the existing literature for a large meta-analysis of outcomes for clinoidal meningiomas. Interesting, 1,200 patients. As expected, the group 1 meningiomas, this one globally, the resection rate is very, very poor. So it's around 10%. Whereas group 2 and 3, as expected, is in the 80s or the 90s. So it shows you why the clinoidectomy is crucial to get to these tumors. But even if you do it, if you have infiltration of the wall of the adventitia of the carotid, your results are still going to be poor for grade 1 with respect to tumor removal, total grade 1 removal, which is never possible in grade 1 meningiomas at least. But that does not mean the outcome is poor. The outcome is still quite good because you leave a very small part around the carotid artery. And if you found a method to protect the optic nerve by a chiasmopexy, you can keep that small residue intact and without growth for many, many years. So the outcome can still be good even if your resection is not grade 1. So the take-home messages for my talk here is that the anterolateral skull base should be viewed as a mosaic of bones. We need to understand the relationship of these bones. The dura and the ligaments form the key. Don't forget there are venous sinuses in the interdural spaces. And ultimately, the understanding of this gives you to understand how they're related to the neurovascular structures. But the key to any successful surgery in this region is the analysis of the bony and the dural anatomy. It is a difficult topic and it takes many years to understand it, but there are dissections in the lab help a lot, and analysis, preoperative analysis with imaging is crucial. And these bones are so different and so intermingled and attached in difficult ways. The 3D anatomy is not easy to acquire. Well, perhaps President Kalam himself had difficulty in shape, so I don't feel too threatened when I say that it's difficult to understand anatomy in its entirety. Thank you.
Roy, that was a brilliant talk. Thank you very much. Really enjoyed that. Just another masterclass talk after the great talks earlier. Really enjoyed that. If anybody has any questions, please feel free to put up on the chat and we can ask those questions, please. There's a question from Bikram Shah. He's asking what precautions should be taken while drilling through the highly pneumatized clinoid process with respect to prevention of post-operative problems, pneumocephalus.
Yeah, okay, so that's a very good question. I mean, the highly pneumatized clinoid process is actually quite easy. So it's important to realize it. That's the only thing. So a CT before surgery can help plan the surgery, but always accept the fact that it gives you a direct communication to sphenoid sinus. So once you know that you're going to enter the sphenoid sinus, it's not a problem. Keep the fat ready, keep some glue ready, and it's easy to close. So I don't see it as an obstacle. In fact, it's quite easy to do it, but just be sure, just predict that you're going to see it and be ready to repair it.
Okay, that's brilliant. Roy, could you unshare your slides so that in the meantime, Jaitang can put up his slides? And then is there any more comments? I think I enjoyed your the way you put up all those cartoons and those sketches and those diagrams. It really helped to understand, even for a spine guy like me, all that skull-based stuff. So, but I do a lot of pituitary, so I enjoyed seeing it from the other side as well. It was fun for me. So I'm sure everybody enjoyed that. Do you have any more comments, questions?
Dr. Ibrahim.
Roy, good to see the sagittal and axial unlocking concepts.
Yes, it is interesting. I think it makes it easier to understand.
Can you hear me?
We can.
Right. Hello to everybody, old friends and new friends. And,
Hi, Ibrahim. Good to see you.
Good to see you all. Question to Professor Daniel. I'm glad that you brought this topic, which is the anterior clinoid, for discussion, because people think of anterior clinoid as a small structure. It's actually, what people think of anterior clinoid is the tip of the iceberg. One can speak of the anterior clinoid as made of a head, neck, chest and abdomen kind of thing. It takes a good deal volume of the anterior, of the laser wing of a sphenoid. So understanding the anterior clinoid as a whole is very important for an ordinary neurosurgeon, let alone for a skull-based surgeon. So thank you for choosing this topic.
Roy, thank you, Ibrahim. It was good to see you there. We have Abdul Aziz Abdullah, who's asking, do you recommend extradural clinoidectomy without drilling? Roy?
Yeah,
I think Roy is...
I always do extradural clinoidectomy for all skull-based tumors. The only time I do an intradural is for the rare aneurysms of this region that I clip. But for all tumors, I think the extradural has more advantages and very few disadvantages.
Brilliant. I think it was brilliant. I really enjoyed those talks. For the earlier presenters, I'd request if you could just look at the question answers chats area and just answer all the questions which are there. Our next speaker is Jaitang. He's going to be talking about variants of subtemporal approach to brainstem and posterior fossa lesions. Jai is a dear friend of the WFNS Anatomy Committee and obviously is going going to be talking something about subtemporal approaches. He works in the China International Neurosciences Institute.
Hello?
Yes, Jai, we can see your slides. Yes, we can see your slides.
Okay, thank you everyone. Thank you, Imad, Dennis, and with the old friend and the new friend. I'm Dr. Tang Jie from Beijing, China. Thank you for having me to share my understanding about the subtemporal approach to the brainstem and the posterior fossa. And good evening, good afternoon, and good days. And now I'm in this buildings. I'm in the neurosurgical the centers here in the fifth floor. My office is here. And so we have many ways surgical approach to the brainstem and the posterior fossa. There's many names and many ways. Some are very simple, some are challenging. And from the anterolateral, just we have heard before, today's from the anterior, from the lateral, from the posterior. Now we have the endoscope in our ways. But today my topic is a very old one, is a subtemporal approach. Sometimes I heard someone call this a subtemporal approach, old one is dead. But I don't think so, because our understanding, our skills, I think this very, very old approach has a skill we have is simple, but very effective and very safe. Simple and safe way. So today,
sorry, Professor Tang, we can, if you could speak a little loud, we can't hear you very well. Thank you.
Okay. So
thank you. I'm sorry.
Okay. How about now? Is it okay?
It's perfect. Perfect.
Okay. Thank you. Because too far. So I think there's many ways from the approaches to the brainstem posterior fossa. Some are very simple, very old. Some are very new and very complex. But now I think the old one, such as a subtemporal approach, is simple, but it's safe. It's also a very effective way for us to do the surgery for the brainstem and posterior fossa lesions. And according to the dura, is a classified subdural approach and epidural approach. I think subdural approach is a very common one, most common. We use it every day. We are very familiar with this subdural approach. Another one is the epidural approach, such as the medial fossa approach or Kawase approach. All this approach, I think so far is epidural approach is an advantage about a good anatomical landmark. And particularly is for the epidural lesion, such as the schwannoma, epidermoid cyst, or the chordoma. So for the subdural approach, we are very familiar to deal with some of the aneurysm, the glioma. So I think this for the according to the dural matter. Another way I think is according to the medial to the lateral. It's classified as some is anterior or medial or posterior the laterals, and all this a little different. And so far in our skull-based surgery, I think the evolution never stopped. And so far we are in these areas to have a simplified and minimal invasive. We don't need so complex or the aggressive treat surgical anatomies now. And we are an endoscope or other reduced surgery or other modalities to treat the patient with without aggressive surgical approaches. And we know it's a subtemporal approach is a very old one. It has been published, used in our neurosurgeon for more than 100 years. And in this book, it's a very good historical review about this involvement of the subtemporal approach. And in 1930s, Dr. Walter Dandy have used this approach, subtemporal approach, to do the lesion about the floor of the third ventricle with these very small skin incisions. And after that, we have a lot of experience to use the subtemporal approach to treat the vascular disease, particularly the aneurysm, and from 1930s to 1980s. And after we have used the endoscope, there's the minimal invasive ways we use subtemporal approach. And also we use this subtemporal approach for the lesions, the tumors in the posterior fossa. vestibular schwannoma or meningiomas. So, and in this paper published by the Dr. Drake more than half centuries ago, he used the subtemporal approach to clip the aneurysms for the basilar arteries. And in his the historical papers, I think it's a very the process in detail, the positioning, the bone windows, and even the incision of the tentoriums. And also it's indicated this approach, subtemporal approach, can reach the lower, the mid of the brain, the basilar arteries. And after that, Dr. Kawase published his papers in 1985. It's an epidural approach to the kind of variant of subtemporal approach. This is epidural approach to the posterior fossa. It's excellent. It opened a good way, open a door to the posterior fossa and the brain stems. And also with his and Dr. Mafti came to China, came to our institute. We have very good communication and course, and we have the better understanding about the subtemporal approach. So far, I think with this subtemporal approach, we can reach at least the trigeminal nerve. So if we remove part of the petrosal apex, we can reach much lower about the clivus and reach the level around the facial nerve. And before I talk about the case, the operation, I want to mention the several points. Positioning of the head is very important. Normally, I want to put the head in this way. So the vertebral, the microscope will go down to the ground, so we can to go behind the cameral sinus. So if the head turn to the opposite side, much more lower, if we go this way, or the approach will to the cameral sinus. Sometimes it will lead to bleedings. Another is about the bone window. The bone window, classically, the subtemporal approach is about 4 to 5 centimeters or long, and the 2/3 is in front of the external ear canal. But if the lesion is predominantly in the cameral sinus, I think this bone window is okay. And maybe we can move it a little bit forward. So if the lesion is invaded to the posterior fossa, we can move this bone window a little bit posteriorly. In that way, the petrosal's range cannot block the view. Another is to protect the vein and to the drainage vein and to protect the temporal lobe. And here there's we know there's from the temporal lobe there's the vein from the lobe to the tentorium. It's the lateral surface and the temporal lobe, or the inferior surface of the temporal lobe. They will go down to the temporal tentorium. So from this side, we can see on the left side, there's plenty of the drainage vein on the tentorium. But on the right side, there's a very few vein. So this way, we will leave the different. If we cut the tentorium, it's different. And also, we need to lift the tentorium, the temporal lobe. We should pay attention to preserve this the drainage vein to keep it patented. So sometimes we know the accurate eminence will protrude a lot, so we have to drill up the accurate eminence. And also we cover the temporal, the lobe with the cotton to keep it white to prevent the damage. And after the surgery, we can use the ICG, just like mentioned yesterday, to evaluate the patency of the vein, the drainage. And also sometimes we can use the ultrasound to detect whether there's a hematoma in the temporal lobe or not. And also another I want to mention is how to cut the tentorium. Normally, just like the Dr. Drake have mentioned more than half centuries ago, I open the incision is behind the trochlear nerve. and also it's to the petrosal range, and along this. Anteriorly, pay attention to this side is closely to the trigeminal nerve, and here there's a bleeding is that it will become very tremendous sometimes, and here some of the case. Firstly is epidurally. Here I want to show from the epidural, the advantage is landmark, anatomical landmark is good, but the space is very narrow. It's not for easy for the beginners to get the orientations. And this case is middle fossa and posterior fossa, the lesion, and is more than 10 years ago. At that time, we used the orbital zygomatic approach. At that time, we loved, I think the young doctor loved the aggressive craniotomies. And we remove the bone, and I'll remove the orbital, the bone altogether. But actually, we use only this part of the for our approach. So it means this area is no use. So now we change this orbital zygomatic approach to subtemporal approach now. But 10 years ago, we used like the orbital zygomatic. So this is the change our standing. And here I want to show epidural approach. It's the space is very narrow, and we can see because of the temporal lobe, the dura mater is a good way to protect the brain, the tissue, but the space is very limited. We have to use the retractor to keep this, and also the epidural bleedings from the venous is another problem. So I think. This is why so far we don't do too much of epidural. And after that, the GSPN was peeled off from the dura. We have the drill. We have the drill, the Kawase, the triangle. We can see the space is not so wide. But that's our beginning, the experience. After that, it had to be the more skilled, but it's not so good as the epidural approach, okay? And then after we cut the dura from the epidural space to the intradural, subdural space to remove the tumor in the posterior fossa. And in that case, after we remove the tumor, we can see this, the third branch, V3 of the trigeminal nerve. Beneath that, there's a structure. This is the internal carotid artery. So for the beginners, we should pay attention to all the structures beneath the branch of the trigeminal nerve. Normally it's the internal carotid artery. Pay attention to this. Normally for the epidural approach, normally we need to drill a lot of the bone, not like the subdural approach. So this is the patient. After that, 7 years, the lesion grows outside extracranially. Intracranial, it's a little bit better. Another is epidermoid cyst. Also, this the last month, this month, the case. This patient is a recurrent epidermoid cyst. About 3 years ago, he received the operation in another hospital, and we can see this like this, almost the same, the size of the tumor. The local doctor used the very skilled orbital zygomatic approach, very huge. But this time in our institution, we use the subdural approach. And from the MRI, we can see this structure. This is the internal carotid artery, is at the bottom of the lesion, epidermoid cyst. And in this, this is epidural the space, and we can see the lesion, this the tumor, but this space is very narrow. So we have to release the epidural from the petrosal ring, and also from the V2 and the V3 foramen odum, foramen rodum, and the foramen ovale to free the epidural, and also I cut the dura to make the space. After remove the lesions, and we can see from the petrosal apex has been eroded by the lesion. So I can see from anterior to posterior, I can see this part is already the lesion in the posterior fossa. And this wall is not broken. And here, this structure is the internal carotid artery. It has been exposed by the tumor. So the tumor is also a good surgeon, a very good assistant to our surgery. This structure, sometimes we can use maybe navigation to localize the structures for the sake. Okay, back to the subdural subtemporal approach for the brainstem. This lesion is the patient suffer from the weakness of the limb, and this lesion bleeding is increased in 8 days. So we have to do operation to evacuate this hematoma. We use the subtemporal approach, and so this is the middle fossa bottom, and anterior, posterior, the superior. So this is about the 3 centimeters in length, and we lift the temporal lobe, and we can see the drainage vein. Sometimes we keep the big drainage vein, maybe sacrifice the small one. After we incision of the incise of the tentorium, we reach the brainstem, and this is the trochlear nerve, and this is the trigeminal nerve, and this is landmark about the venous lateral the sulcus of the trigeminal, and this is there's a change of the brain tissue, so it means that there's a bleeding, and we go down, we can reach the hematoma. So we magnify the microscope, and we go surrounding the lesions, and then we remove the lesions piecemeal. Yeah, all this should be done in very gentle way, and remove all the lesions totally. Normally, when we remove all the lesions, there will be some bleeding. So this is some kind of the venous bleeding. It's not, we just use some the sponge to compress. The bleeding will stop. Or we use the low power bipolar for the coagulation. So now we can change the microscope to reach the inferior part of the lesion. Is the level is around at the facial nerve level, and we can change the microscope to the anterior superior part. So in this, we can reach the lesions in pons of the brainstem. Another one is a petroclivar meningioma, but here is not a big one. But this is very interesting. This lady suffered from the facial pain for 3 years. And 2 years ago, she received the gamma knife, but the symptom didn't improve, and also the tumor grew. And we can see there's lesions in the petroclivar in the macro cave. So we did this. Can you see the movie?
Not yet. We can see it says video clip. It's not running. Tang, we have 1 minute left. If you could please wrap up.
Sorry. Sorry, we cannot do. I have 1 minute.
Yes, please.
Okay, so 1 minute. Okay, so I open you can see the video now.
Yep, we can see the video.
Okay, so the tumor adhere to the trigeminal nerve. Here, I want to emphasize we cannot expose the tumor behind the petrosal, and we remove this part of the bone. So this is subdural draining, drawing is tailored. There's no need to drill too much of the bone and expose. And also we can see this is the abducens nerve. So we can drill this bone to expose, and also we can have a very good view to see the posterior fossa, even the 6 nerves, okay? Okay, so this is I want to share with my understanding about the subdural approach. So it's an old one, but it's still very useful and safe one. Thank you for your listening.
Thank, that was really a nice talk. Really enjoyed that. I think explaining every aspect, starting from the history and going on to what we are doing today is amazing. So really enjoyed that. There's a question that we have from Parvat Kumar from India, and he's asking, is this necessary to remove such deep subtemporal hemorrhage? If you face bleeding, how can you manage this?
Can you repeat? Sorry.
So if you're operating that deep subtemporally, and you're operating for a clot, then if it bleeds, how do you manage it?
You mean CSF leakage?
No, if you're talking about a bleeding there, if you have any kind of bleeding there, how do you manage bleeding in such deep part?
Deep part what? I cannot.
It's basically you're operating that far away from the surface. So that's the question Parvat is asking. Parvat is a junior consultant. If you have bleeding, how would you control the bleeding?
What kind of, where does bleeding come from?
This is not, he's just asking a question. Pablo, maybe you could help him?
I don't, because you know, there's bleeding, you mean from the tentorium or from the...
What I understand is that if you are working deep, close to the tentorial incisura, with this narrow space, if you have a bleeding there coming from the tumor or from some vessels surrounding the tumor, how do you manage to find it and to coagulate it in such a small corridor? Do you have any trick?
You mean subtemporal approach?
Yes.
Actually, I don't. So actually we use the subtemporal, we have the much more space. You know, if the tumor is from the meningioma, we can coagulate, we can expose, and we can coagulate the tumor's attachment to the tentorium. It's not a problem. It's very easy because it seems very limited space initially, but when we release the CSF, there is a lot of space. It's much more than the epidural approach. And if the tumor, and sometimes the bleeding is come from the subtemporal vein. For the venous bleeding, we just use the sponging for compress. It will stop. It's very efficient. It's no problem. It's not some kind of the arterial bleeding. So it's the same. Initially, it's the same. It's very limited, but after 5 minutes, it's very wide. Just like we to see some views, and after you see it open so widely, so it's not a problem. I think.
Okay, there's another question, Tang. This is from Kazadi, our dear friend from Africa. He's asking, do you use lumbar drain to relax the brain to take away CSF?
Okay, it's a good questions and a very old questions. Initially from the books, we know the lumbar drainage is a good way for the drainage. But to me, if the patient have the hydrocephalus, obstructive hydrocephalus, if we do the lumbar the drainage, is some risk. And if in such the circumstances, I prefer to do the external puncture of the ventricle puncture drainage. Another way, I cut a little bit the dura, the temporal dura, to release the CSF gradually. And also, if we use the lumbar drainage, we should keep an eye on the volume of the drainage. It's normally it's no more than 20 or 30 milliliters. In our practice, there's sometimes we're doing it too much. The bone is falling down. Is a risk of the epidural hematoma. Lumbar puncture drainage is a good way, but I not rely on the risk. Okay.
Okay, thank you.
I want to just add to this comment. I think
Sure.
temporal lobe, most of the complication occurs from excessive retraction by the subtemporal approach. And I think it's worth, if there no big mass effect, you can put the lumbar drain. Otherwise, I agree completely with an EVD to relax the temporal lobe. Of course, until you reach the cistern, if you can open a cistern and release and you get the relaxed temporal lobe, then fine. But don't put retraction on a swollen temporal lobe, because the damage and the complication are supersede the value of the procedure.
I very much enjoy the talk. Maybe if I can brief comment.
Sure.
Yeah, CSF is always greatest enemy, but also can be our greatest friend. And what I find useful is before, let's say, going a bit more posteriorly towards the brainstem, if we have to operate on the brainstem, I like to go a little bit more anterior and open the basal cisterns there, because the basal temporal veins are mostly located more posteriorly, and then we have also pyramid and so on. So if we go a bit more anterior towards the carotid cistern and Sylvian fissure and so on, quite a lot of CSF can be released from there. Just another little trick.
Okay, brilliant. I think thank you, Tang. We're going to move on to our next speaker, and that is Eckhard Kasper, a dear friend for a long time. He's from Hamilton General Hospital. Eckhard, are you there?
Yes, I'm here.
Yes, brilliant. So if you could share your slides, then he's going to be talking about Telo-vela approach to posterior fossa. He's from Ontario.
All right. Can you see my screen?
We can see you at the moment, not your screen.
I did press share screen button.
It takes a few seconds.
Hang on 1 second.
Brilliant. It's coming up.
It's coming
You're
up?
there. Yeah, it's there.
Excellent. So let's hope for this one. Let's just keep it this way. So I'm happy to contribute to today's webinar with a talk on the Telo-vela approach for lesions in the P fossa. And I appreciate Tom's help in putting this together. I have nothing to disclose except some slides were taken from Tom's and Ramesh previous dissections and presentations.
Okay, could you
With
share
my outline?
your, yeah, sir, if you wouldn't mind, if you could just make this into a
Bigger?
larger, yeah.
All right.
Brilliant. That's very good.
So I want to take you through the problems, the available options, obviously the anatomy and some risks from surgery, and a roadmap to success. From my perspective, P fossa lesions can really be divided into two types that are suitable for this approach. These are the midline lesions located in the fourth ventricle and lesions laterally in the foramen Luschke or lateral recess, which are accessible through this way. There are different types of neoplasms that you may encounter. In the adult population, it's largely ependymomas and subependymomas. In the pediatric population, you probably meet more choroid plexus tumors. And in non-neoplastic lesions, you can work on infections with this approach. What is the surgical problem? If you look at this, it's really the question how we get from here, posterior view, looking at the vermis and the cerebellar hemispheres, to inside the ventricle to remove whatever you want to remove. Access doesn't appear to be easy because if you look at the preparations in the cadaver lab, there are lots of anatomical structures you really need to understand from the midline to the parasagittal cerebellar components. But if you add on vessels as injected here, the cadaver lab, it's a little bit overwhelming. So there are several routes to get in, and it obviously started all with dandy and midline approaches. So the two classic approaches for this problem is the transvermian approach, coming through the midline, working from medial to lateral, or coming from lateral, transcondylar, and working from lateral to medial, but you can easily see it's difficult to reach the midline. Can somebody mute?
Sorry, Tang, can you please unmute yourself?
So in my view, the problem is that these classic approaches are somewhat outdated because the midline transvermium approach really has significant postoperative morbidity. If you make a cut just following the inferior vermis midline down, most patients end up with some form of speech trouble, aphonia, or worst case scenario, cerebellar mutism, dysarthria or ataxia. But you often also have motor dysfunction, truncal hypotonia, dysmetria, and ataxic gait. In addition, there may be behavioral problems such as memory and cognition problems, to name a few. The far lateral approach, as nice as it is for extraaxial lesions like vascular aneurysms of the pica and vertebra, comes with problems exposure-wise. There are often patients complaining about problems with the neck muscles post-op. There are neuronal structures on the way in, and the vascular structures, including the vert as it curves, gives you a relatively small window of opportunity to get in there. So I think the solution for many lesions, as I mentioned in the midline and laterally, is really the cerebellomedullary fissure approach or Telo-vela approach, largely championed by the team around Roton, but equally advocated by Yajigil and some other colleagues. What is this approach? The Telo-vela approach is really smart because it avoids splitting of the vermis. It allows us to come in from the midline and allows to go through natural planes using clefts that are there from embryology to access the fourth ventricle down to the foramen oluschka laterally. You can really access three different areas with this approach. In the midline, obviously, the body of the ventricle up to the aqueduct. Laterally, you can go to the lateral recess, and you can even reach lesions in the lateral wall of the lateral ventricle if need arises. To make this simple initially, I want you to divide the space of the CMF into two components. There's an upper component, which is the space between the vermis and the tonsil, called the uvulotonsillar space. There's an inferior lateral space, which is between the tonsil and the medulla, the medullotonsillar space. Now, if you look at the same space from the side, what we are really trying to do is we try to unlock the roof of the fourth ventricle in the inferior velum. So that's the roof of the fourth ventricle we want to elevate. And if you look again, posterior exposure at a patient in the prone position, you want to use the talar choroidea, which is your lock, and extend that incision to the lateral recess across the limbus, giving you access to the foramen. For surgical purposes, there are two ways or three ways how you can do this surgery. What it has in common is all patients really are in the prone position somehow, and you should really flex the patient in the atlanto-occipital joint as well as in the cervical spine. And you can operate either upright, so I'm a right-handed surgeon standing to the left shoulder of the prone patient, working my way up, just like the way I do Chiari decompressions. But I could equally well operate standing at the head of the patient with the patient facing you head first and anesthesia and the body of the patient being there. This is how the patient is positioned, and it's important to position the patient in flexion, and you should use preoperative imaging and intraoperative guidance, not so much to find the tumor, but get your axis of viewing angles right, especially when you do this the first few times. So these are, again, the two options for tumors. If you go for a midline tumor, I recommend a midline incision, just as I said, sorry. You can do a midline incision standing at the head of the patient. This is what the Cambridge group does, and Tom has given me a video I'll show you later. Or you can do this standing from below, just like a Chiari decompression, opening the midline. If you work in the lateral portion of the ventricle of foramen oluschka, you can do a 3/4 prone position and do an asymmetric opening of the dura. What is the advantage of this positioning? If you look at the neutral position, you will have a straight view down onto the cervicomedullary junction, but you can't really look into the ventricle. By providing a military position with the chin tuck, you can align your axis of viewing to look under the tonsil up all the way to the aqueduct, really looking into the upper fourth ventricle, and you get a panoramic view of your surgical field. I always use intraoperative monitoring for tumors in the fourth ventricle. All cranial nerves, direct nerve stimulation should be set up. Monitoring of SEPs and MEPs is standard of care. This is a bit how it looks. A standard Chiari opening would look rather similar. So take your time to make a good dural window. It's some form of a Y shape for a midline tumor and a variation thereof for lateral tumors. Then when you have taken off the dura, you want to take a moment and pause because it can be a bit overwhelming. You know that you have to get in here somehow into the foramen or GND, posterior opening of the fourth ventricle. So break it into simple steps. Here's a drawing I made a few years ago for a paper we did. So I think step one is identifying the junction of the medulla and the tonsils. Step two is you actually elevate the tonsils and pull them laterally to see your talar the first time. Then you cut the talar from medial to laterally at about a 30-degree angle to go to the Telo-vela junction, which unlocks your thing. And this is how it looks in the cadaver lab without vessels. Again, find the obex first, identify your talar. Once you've seen the talar, identify the talar and the Telo-vela junction by elevating the tonsils further. Take out the talar from medial to lateral, and if need be, you can extend this laterally over the limbus to unlock the roof of the fourth ventricle entirely. Now the vessels added in. You can see it's getting more complex, but you start again at finding the obex and the opening of the fourth ventricle. You then elevate the tonsils and identify the talar in this spot. Now it's a moment to take a break and make your zoom in magnification larger. You really want to see the vessels in the talar and especially the veins in the cerebellomedullary fissure. Bipolar this carefully, start medially, go laterally, and split this under the microscope. And then take a moment and orient yourself. Name the structures you recognize, and you will have a good view into the fourth ventricle bottle, choroid plexus, and obex. This is a schematic diagram Tomasello, has provided in his paper. I want to recommend this paper to all learners. It's a nice schematic diagram that takes you through the steps, and it comes with a video clip explaining why you should come in from medial and work your way up and out. Tomasello's video is nicely annotated in the upright position. It shows you the obex and how you take out the talar before you can expose this tumor. I don't have this available here right now, but I would like to share with you the series he reported on 45 patients with a number of different indications. They said there's no increase in infection, bleeding, wound healing rates, or CSF leak. They didn't encounter any strokes and could preserve all picas. One patient had a coma and death from the primary lesion that bled, unrelated. There were minor cranial nerve deficits in 3 patients and no case of cerebellar mutism, which is the great advantage compared to midline transvermian approaches. Now, how does this look in vivo? And I want to share with you the video clip that Tom gave to me from Cambridge. Now here the patient is positioned upside down with the head towards you. Midline incision is made, so caudal is here, C1. This is the cerebellar hemisphere, and this is the exposure of the arachnoid over the area we are trying to explore. So let me just share this with you. I hope either this works. Oops, it doesn't. Let me just click onto the movie. Can you see the movie?
Not yet.
Is it coming?
Not yet.
All right. Hang on one second. I go back to screen share. I need to share a different screen. 1 second. I want to share a different screen.
Maybe just go up and unshare and then screen share again, because you won't be able to see the second screen. Or you can, if it's a Mac, you can just turn it on.
It's not a Mac, that's the problem. So okay. Does anybody see the screen or not?
We see the screen of the picture of Telo-vela approach works for different lesions. That's the one that we see.
All right, I'm sorry, I need to go back into the presentation. There was a problem with changing this to a non-Mac. All right, can you see it now?
It's doing something, but we still can't see the video yet.
All right. So this was a patient.
Can you try, instead of stop sharing and start sharing again. And instead of sharing the PowerPoint, share your screen.
All right, I thought I did that. Give me a moment.
Your desktop, I mean, everything, not the PowerPoint.
Yeah, let me take a moment. Sure, guys, I apologize, but for some reason, sure. So do you see the screen right now with the in vivo picture and there's an icon of a video clip?
Yeah, that's
Okay.
what we're seeing. So just unshare, go back into your computer, and then screen share again and click on the video which you have already opened. Yeah, so just open your video wherever it is, have it ready, and then screen share.
Okay, here we are. Sorry, I apologize. So this is a patient, 48-year-old, presenting with dizziness, unsteadiness, headaches, blurred vision, and some deteriorating short-term memories. As you can see, there's a lesion locked into the fourth ventricle upper portion on this T2 sagittal film. The lesion is non-contrast enhancing on this set of films, and it seems to originate in the roof of the fourth ventricle, but touching the floor of the fourth ventricle. Tom, feel free to chime in. You know this patient better than I do. As I mentioned before, the patient is positioned in flexion, and this is the top view down. So here is caudal, there's cranial. Tom is opening the midline to identify the first step, which is identifying the medulla and the tonsils. Now he's trying to separate the two tonsils to identify egress of CSF from the fourth ventricle and identifying the foramen margin-D in the midline. A retractor can be used. I use stationary retractors from a Greenberg set, but a lot of people have an assistant and use a second person helping to retract the tonsil. And here's the opening of the fourth ventricle. Inferiorly, you see probably choroid plexus pouring out a little bit, and some CSF can be removed. And now Tom is starting to unlock the tonsil and the arachnoidal adhesions from the pica, and then you can continue medially. Here's the fourth ventricle opening, and this is the talar takeoff, where you try to pull back the tonsil to unlock the roof of the fourth ventricle. First ipsilateral, here's the choroid plexus visible, floor of the fourth ventricle. Opposite tonsil is visible on this side. This is the cadaver view again. We are trying to take out this portion of the talar at this point. We are trying to go in. This is the same view I had shown you before, upright. Obex, midline opening. Pull the tonsil to the side, identify the talar choroidea. We're going back into the OR in a second. We want to have this as the final view we would like to see. So here now you see the fourth ventricle, floor opened. Here's again the obex upside down. On the right side is talar choroidea. Here is choroid plexus, and now Tom is working on the opposite side, trying to open that talar choroidea to unlock the roof of the fourth ventricle, which would come at you, elevating the fourth ventricle, which gives you increasingly the ability to look into the fourth ventricle and identify this tumor. Then as you identify the tumor, the nice thing in ependymomas is you can actually create a plane that separates the lateral wall of the fourth ventricle. The tumor can be peeled off, for example, with the roton number 5 or 6. And you should not use bipolar cautery on the floor of the fourth ventricle ever, because you really have very sensitive structures, and anything that you fry in this location will cause a cranial nerve deficit. And as the tumor is progressively mobilized, you can see the upper portion of the tumor here that can be peeled down, lateral portion of the tumor here that can be freed up with a sharp dissection. You can look under the tumor, see the floor of the fourth ventricle. Finally, you can use the CUSA to mobilize some of the bulk of the tumor. And if you're able to now CUSA out the bulk of the tumor, you should be able to create a clean margin with CSF pulsations up from the aqueduct. Oops, I just want to show Tom showing his successful operation here. And they are doing all this in 3D, which is pretty amazing. So I really appreciate, Tom, that you shared this video with us. So I want to go back and share the rest of this brief presentation. This is the last few minutes. So this not only works for subependymomas, but I want to show you from a paper we published a few years ago. Here's a meningioma that didn't look like a meningioma to begin with, high riding in the fourth ventricle, showing, a really difficult location to reach because you can't go with the steep tentorium in any way or shape. Infratentorius for cerebella, you can't get over this hump, right? But if you come in from below and you unlock this the proper way, you can really reach up all the way to the aqueduct. So we were able to chisel this out without any complications. This also works for pediatric patients. This was a solitary fibrous tumor, WHO grade 2, that my friend Rio Leo from Beijing took out in a very smart way without any side effects. And finally, this is the most typical case I think you will see. A partially cystic, partially solid tumor, looks like an ependymoma. You see how intimately the pica branches are involved. Coming in from below, you get perfect exposure of the pica. So we were able to chisel out every single branch from the pica without losing any. And finally, the pica is post-operatively flapping in the breeze, and we didn't lose anything and didn't have any complications. Now, during the surgery, you can decide whether you need an extensive type of opening of the CMF, whether you can actually limit yourself to a unilateral opening or even just a small opening of the tela towards the foramen luschke. So if you have a large fourth ventricle tumor, you make bilateral openings. If you have a unilateral tumor, you may just end up with taking out one side of the tela choroidea. Now there's a nice paper by the French group of Jean from 2003 that shows the unilateral exposure, same steps, elevating the tonsil, identify the tela choroidea from the obex and foramen laterally over the limbus. And post-operatively, they can show tumors located in the foramen are easily resectable and accessible this way. Now, I want to show you two pearls to finish up this talk. This is a patient that came to me maybe 3 years ago with this very strange ring-enhancing lesion at the bottom of the fourth ventricle, lodged to the side between the medulla. And I got pre-surgical Fiesta T2 thin cuts showing you one of the cranial nerves is somehow close associated with this. I couldn't tell what this was based on imaging. So I got an additional set of pre-surgical CTA thin cuts to look at the vascular supply, which wasn't so bad. And I also got DTIs to see, is my fiber tract truly displaced anterior laterally? And luckily enough, I was. Here's the pyramidal tract in blue. There's no risk if I come in from posterior taking this out. I just have to be careful about this cranial nerve. So I monitored all cranial nerves. And you can see that during the surgery, we did the Telo-vela approach. We only took out the medial portion of the tumor because each time we dissected the lateral portion, the 10th nerve that just came off laterally was stimulated, and I didn't want to cause swallowing difficulties post-op. So we were able to take this out and leave a small portion of the tumor behind because intraoperatively, we were told this is likely a ganglioglioma WFNS grade 1. So there's no reason to be aggressive and leave the patient with a deficit. This is one other case that I think is interesting. This patient coming with the large mass in the P fossa, both in the ventricle.
Kurt, I'm sorry. Okay, I apologize. If you could just make that full screen
Last
again.
slide.
Yeah, but just show because guys are unable to see properly. If you just enlarge this and show a full screen.
Oh, sure.
I'm sorry.
I apologize. So this is the tumor, space occupying lesion in the fourth ventricle and reaching out through the foramen luschke, even anterolateral to the medulla. On DWI, you see this is an epidermoid that grows in a funny shape. And we were able to approach this lesion through the Telo-vela approach. Here you can see how we came in. We were able to resect the lesion, use the same corridor, opened up the lateral recess, and this is the post-op DWI showing a total resection for this lesion. So I think this is a very useful approach, versatile for a number of different pathologies, carries a relatively low risk. Don't get me wrong, this is still a high, manual skill procedure, but it gives you perfect exposure, which helps you to really minimize side effects. So conclusions from my end, intraventricular surgery is actually fun. Think inside the box and really know your anatomy. Be safe with your approaches. Go to the cadaver lab and try this out on one of the courses. Don't do this the first time on a patient. Think outside the box, unilateral versus bilateral openings, and use a lot of common sense. If you think it's risky, slow down, zoom in, zoom out, and go one step at a time, break it into manageable steps to be able to remove your lesion. You will see it's rewarding. Thank you very much.
Ikar, I think amazing talk as always, super, really enjoyed that, and especially the anatomy bit of it and how you went through from looking at the cadaver and coming into the surgery itself. It was amazing. Really awesome talk. What about the pediatric population? Have you done this in pediatric population?
So in my particular setting, you know, I operate on adult patients only. The pediatric hospital was both in Boston as well as Hamilton, a separate group in a different location. So I don't see any pediatric patients. We just share conferences. But I think for choroid plexus tumors, especially, that are rather prominent in the age group between 0 and 2 years, that's an excellent approach. And the only problem is with an immature skull, how you pin them. So you may not be able to pin. You can immobilize the patient on a hockey-shaped donut and tape it down. And once you're a little bit more experienced in this approach from the adulthood, I think it's a very suitable approach for this particular situation. Yes, Dr. Ibrahim.
Okay, excellent.
Do I have a question?
Sure.
Thank you, Dr. Kasper, for this presentation. I enjoyed it. This approach, as you mentioned earlier on, that it is indicated in certain cases, it's not good for all serous tumors. So it's a good way of doing things. But I have done hundreds of posterior fossa surgeries with the splitting of the vermis, and I've never ever had any problem with cerebellar mutism. So I think lots has been said about cerebellar mutism more than what it actually exists. And I would love somebody would tell me what is the pathophysiology of cerebellar mutism. If
So
anybody...
I think I can help you a little bit with this part. I think, yes, there are still occasions where even I use a midline approach, vermian split. If somebody has a hematoma and is at risk for life, and you need to be rapidly in and the lesion reaches the surface, you can't waste your time in trying to chisel out the fine details of the anatomy. Then you may create a mini hole in the inferior vermis to gain access to the hematoma. But I honestly think the minute you reach deep and you damage somehow the connections to the dentate nucleus, you're in major, major trouble. So if you can avoid cutting any fiber tracts, the natural instinct should be go through natural clefts without cutting any white matter, because that will definitely help you. I agree. I've heard from experienced surgeons, and Eka gave a talk last seminar that he takes out lesions through inferior vermian splits. In my hands and with my colleagues, the results did not work out as well as this one. So I have switched over to this approach, which is technically a little bit more challenging, but has lower risk from my own experience.
Well, if there is something that you can do without splitting the vermis, there is no need for it. So with orienting the microscope, shifting the patient, shifting the patient down and up, and after doing a Telo-vela approach, you can reach almost anywhere. So you really don't need to split the vermis. So that would be the answer. It's when you can do it without splitting the vermis, why would you want to split the vermis?
But the point is that you need sometimes to split the vermis, and the fact that many neurosurgeons, including myself, including many French neurosurgeons, pediatricians, famous people, they've never had any problem with cerebellar mutism. So we talk a lot about cerebellar mutism, don't touch the vermis. When you split it, nothing happens. Now, you cannot tell me that splitting the vermis does not add to your vision and to your microscope direction, even in the prone position. So it is important that we know that sometimes you need to split the vermis and that the danger of doing so is very minimal.
If I may to join the sort of conversation here, I quite agree. The literature about vermis per se is rather limited, and the evidence is rather limited. And in terms of the anatomical substrate, nothing's been proven, but it seems to be the output from the cerebellum that is responsible for what we call cerebellar mutism, and which means dentate and other cerebellar nuclei, and particularly the superior cerebellar peduncles, and particularly if this happens bilaterally. Now, as much as it has very little to do with vermis, I think the vermis comes to play when, particularly in certain type of tumors, such as medulloblastomas, one pursues the tumor either too aggressively, and he can do it equally, well, I won't say equally necessarily, but from the Telo-vela approach, or from the vermin approach. So it is probably quite true that the cerebral mutism doesn't happen with injury to the vermis per se, but one can, particularly going upwards, can get lost, because if one looks at the anatomy, the dentate nuclei in particular are quite close to the roof of upper half of the roof of the fourth ventricle. So I suppose that's the danger, and I quite like in a way the point by IP that, you know, whenever we can get somewhere without damaging somewhere, probably even better. So although it will not necessarily cause cerebellar mutism, it may perhaps lead to truncal ataxia and so on. So yeah, but I think your point was very important, that that one must not get dogmatic the opposite way either. Yeah.
Yeah, I think I agree. So I started out by doing vermin splits initially, but you know, have switched, and not because of any complications that I've seen but of the reports. And it's just that anatomically, this is a much better approach that I found without damaging anything. Just like we are trying to avoid any fiber tract that's going anywhere, we need to try to avoid any problems if we can. If we are used to it, we are happy, you know, you can. But like if new guys who are coming in, you're teaching them, I think we need to be trying to doing things in order to make sure that we don't take any tracks when you're doing this.
And I
Tom,
want to
you're
just
not...
emphasize again, it's not just the mutism. Actually, ataxia is a debilitating problem, right?
Sure.
So if you have a motor skill that is severely compromised, your quality of life goes down tremendously, which may be from the lesion, Dr. Ibrahim, but it can also be from you as a surgeon, or from me as a surgeon. So for that end, I think Ibe's point is exactly what I advocate here as well. If you can avoid going through any fiber tracts, by all means, take the time if you have it, right?
I totally agree. Tom, you're not running away. You're going to be moderating from here on.
Thank you very much, Simon. Great moderating. From the new world of Canada, we are moving to the old continent, and I hope and believe that we have among us Professor Miguel Arraez.
Here I am. Hi.
Great friend of mine, joining us from the most wonderful city of Malaga, unless you are somewhere on holidays.
No, I'm in Malaga. You all are invited to come.
Thank you very much. We'll definitely arrive there in hundreds. And you'll be talking to us today about Clivus chordomas, because I know very well that you have both endoscopic and microscopic experience extensively. I can hardly think of any better person to take us through this topic. There you are.
Thank you very much. Okay, I hope you can see my slide, right?
Yeah.
Okay, so first of all, thank you, Dr. Santoris, for the presentation. I'd like to thank my very good friend, Dr. Kanan, and also Vladimir Benes, and all the friends involved in this successful and wonderful WFNS committee, Salman Sharif, Pablo Gonzalez, all the friends. So my topic is about the anatomical extension in clival chordoma, and until which extent may just lead us to the decision of microsurgical or endoscopic approach. I think that all roads led to Clivus. This is a phrase of our very good friend Sam Al-Mefti, and I have to mention that there are many possibilities. Of course, I will focus on extradural approaches. And I have to mention also that during the last decade, the microsurgical approaches, transcranial, transsphenoidal, and transphysial approach has been presiding this way of working. This is a patient operated on by us in my former institution in Granada. As far as 1993, you can see this huge lesion compressing the brainstem, also compression of optic pathway, and the way we manage that big cases in the 90s. This is the extended subfrontal approach, very well known. You can see one of the publications by Dr. Sen, Dr. Sekar, and the way you can just do this complex osteotomy. Next step, decompression of extradural decompression of optic nerves apparatus, as you can see here, and then drilling down the clivus and through this tunnel trying to remove the lesion inside posterior fossa. In that case, fortunately, a suckable lesion. You can see the extension in between both cavernous sinus, and the final result very satisfactory. Also, we just did cases through transsphenoidal approach for lesion involving the posterior fossa and the middle third of the clivus. Transsphenoidal approach is used and has been extensively used. You can see reconstruction with fat graft. And also we used to do this approach popularized by Professor Crocker, open door maxillotomy, that is a Lefort-1 osteotomy with midline splitting, as you can see here. This aggressive, you can see the Crocker retractor, removal of the lesion, in that case extradural, and usually followed by very good satisfactory result from the functional point of view by means of this fixation of microplate. We did many cases, I have to mention, and we were very happy about this approach, because even those cases, hourglass fashion, could be removed, as you can see in this very short clip. See the retractor. We have to release the retractor every 15 minutes, trying to avoid any damage, ischemic damage to the hemimaxilla that was troublesome. But in any way, an approach very nice to remove the lesion. See the anterior part of the brainstem, vertebrobasilar artery, and you can see lower cranial nerves, and the reconstruction we used to do at the time with fat graft and spinal lumbar drainage. We did many cases. This historical part of the presentation is something nostalgic for me, because later on endoscopy came, and I think that came to stay. We all know this way of doing things through the nose. I will try to move forward, because the real issue, we can see here the real issue in endoscopy. This is something we could never see through transmaxillary or transesmoidal or transfacial subfrontal midline approaches. This is the anterior optic carotid recess, and this is showing how endoscopy has the advantage of showing in an eye-fish fashion this almost 360-degree around the lesion. This is the real virtue, the possibility to see better. So we just did some conversion from microsurgery to endoscopy for chordoma case. This is one of our early cases. At that time, we were still linked to unilateral uninostril approach with two hands or two hands technique, but in any way, this lesion with this big impingement at the brainstem could be very nicely removed by this approach. You can see fat graft reconstruction at that time, still using some ways of making the reconstruction according to the microsurgical fashion. If we look at this case, we will have some remembrance of the initial one, compressing optic nerves growing toward posterior fossa. See the extension, small involvement at the cavernous sinus by basically an extradural lesion that by means of endoscopy we managed to completely remove. See the reconstruction with fat graft and the pericranial graft. And also very important to mention, this is another chordoma case in a young patient. Also important to mention that we have have had to incorporate the way of making reconstruction with nasoseptal flap. You can see here one of these examples, and the way we try to adjust, inflate the balloon, and after that release the pressure to see how the whether or not the flap has been completely incorporated to the inner surface of irregular inner surface of the sphenoidal bone. And when everything seems to be solved by endoscopy, this patient came from another place, biopsy in another institution. You can see this posterior fixation, not very satisfactory. The patient couldn't be at the recumbent position, was sleeping in a chair for 4 weeks because she couldn't breathe. And for cases like this one, of course, you can do endoscopy. Some people do that, but I think that this is a case that deserves a classical skull-based approach, high anterior cervical retropharyngeal approach. And by means of this approach, we just managed to anteriorly remove this anterior portion. In a second stage, just eliminate this not very satisfactory fixation. We also have to be accustomed to the new material and new ways with the screws, and so see the fixation and see this, the evolution of the patient. Sorry. One of the rocks broken due to the huge instability. We had removed in a first stage the anterior part of C2, in the second stage fixation, and also complete removal of the posterior part of C2. This was something that the hardware couldn't stand, and you can see this bracket, but later on, fortunately, was an anterior fusion, making stable the construct, but later on, the patient recovered. And we did another resection just for fixation. We use fibula, cadaveric fibula, you can see here, and this is not the tumor, this is the replacement of this area by means of iliac crest. Satisfactory result, as you can see here. This patient was operated on first time 9 years ago, and 2 months ago, you can see this recurrency here at this part. You can see the displacement of the vertebral artery and the intraoperative view. This is the vertebral artery and the removal of the lesion just by means of a far lateral approach. This is an example of how you cannot, you shouldn't consider endoscopy for everything in chordoma. This is another case. Sorry. See this huge lesion involving also the anterior and lateral aspect of foramen magnum. This is a slide after endoscopic removal. This sagittal view seems to be all right, but if we look at the coronal view, we can realize how in chordoma cases, the most inferior, posterior, and lateral aspect cannot be easily removed, and if so, you will provoke some instability you cannot manage from anterior. So for cases like this one, you can see this part of the tumor left behind. We plan a transcondylar approach. We are at the right side. This is vertebral artery just right before getting inside the dural space, the drilling, and see how we can do a real condylectomy, drill around and try to remove this case in that particular occasion, not very easy to be removed, and the way you can work. This is just right in front of foramen magnum. So the anterior aspect of the medullary region, anterior foramen magnum, can be very nicely approached through this transcondylar approach. If so, you have to be familiar with the new techniques for occipito-cervical fixation. In this case, unilateral fixation. You see the screw at C2, and also the rods and screws at the occipital bone. And this is another example. So you see the lesion that is in this aspect growing inferiorly, laterally, and posteriorly, not very good for anterior endoscopic approach. See how the lesion is going up to the tentorium. It's not an easy case, but anyway, very nicely, we managed to remove all this part of the tumor, but we have some part that we left for a second stage through transcondylar approach. See, after transcondylar approach and removal and fixation, in this case, to the lateral mass of C1 that was, let's say, healthy enough to stand the fixation. In some other cases, we just decide to do directly the transcondylar far lateral approach. This is another patient. You can see the lesion here that is involving the inferior third of the clivus, involving anterior foramen magnum, and also involving, as you can see here, CDJ, that left side. So we use in that particular case the left side to do a direct transcondylar approach, and you can see the MRI after removal, and this is a postoperative MRI, and you can see a very good, very satisfactory resection through a pure transcondylar approach without any endoscopic route. Last part of the presentation to mention that endoscopy has a tremendous and very important role when managing chordoma in kids. We see chordoma in kids from time to time. You see this very funny way of growing that is in kids, basically coming from the posterior part of the sphenoidal bone toward posterior fossa. See at the same time the disposition, the anatomical normal disposition in kids with horizontal mid-base, and by the way, less development of frontal sinus that makes approach to the clives a little more difficult, but in any way we have to drill out until reaching posterior fossa in order to make the removal of the lesion. This is a tumor with involvement of both cavernous sinus. You can see the drilling, aggressive drilling, and this is postoperative MRI with some part of the tumor inside cavernous sinus due to problem with the involvement of cranial nerves. We decided to manage this small part that was sent for proton beam therapy. This is another kid, 5 years old, with 6 nerve palsy at the left side. You can see the chordoma. Again, how the lesion is growing at the posterior part of the basiosphenoidal bone, and the way we manage to completely, this is an immediate postoperative MRI showing the removal of the lesion, very satisfactory, with improvement of the 6 nerve palsy of the patient, and the patient discharged 5 years after the operation. And this is another case. This is a complex chordoma. You can see the growing inside posterior fossa, big lesion, but the lesion is in between both cavernous sinus. Fortunately, the lesion was completely extradural. I'm talking about foramen magnum. The lesion is not involving the lower third of the foramen of the clivus. That is to say, this is a lesion that 100% has indication to our knowledge of endoscopic approach. And this is the way we managed to completely remove the lesion. This is fat graft and nasoseptal flap, trying to in any way assure a complete reconstruction of this part. So my last comment in one slide is regarding conclusion. Revolutionary approaches coming from endoscopy, of course. We just did embrace endoscopy as a formal approach for pituitary and skull base more than 13 years ago. Endoscopy and microsurgery must be complementary techniques. This is something important to be transmitted to the younger colleagues in the audience, and also to the senior colleagues. My personal philosophy of approaching chordoma is according to the extension. Upper and middle third are done by endoscopy. Lower third and C0, C1, C2 involvement are better done by microsurgery. And we have seen several examples in which the combination in 2 stages of these techniques can be something really useful for the macroscopic removal in those difficult cases. Last comment to junior and senior neurosurgeon, because some people, you all know the debate that is every day coming up. Microsurgery, endoscopy, yes, not. I think neurosurgery needs any philosophy able to help the patient, and we all have to try to control in as much as possible and to master the microsurgical techniques that solve a lot of problems and endoscopic technique. Thank you very much for the invitation, again, to my friends of WFNS Neuroanatomy Committee.
Thank you very much. There was a most balanced and most pleasant talk based on extensive experience. Any questions from the panelists? Any comments from the panelists?
I have one question.
Professor Ibrahim?
Ibrahim, unmute.
See you.
Yeah, now we can hear you.
Okay. Hello, Miguel. Nice to see you. Wonderful talk. Thank you. I just want to ask how much did you need to do fixation once you do the occipital condyle drilling? And what was the percentage of hypoglossal nerve damage in those cases where you had to do this occipital condyle drilling?
Well, you know that in chordoma cases, usually what you have to do is following the tumor and try to drill around. So talking about that in regard to the transcondylar approach or far lateral approach, you very easily, you have to expose vertebral artery that the critical structure, and you have to, and very easily you can follow the tumor. You can drill around, and regarding 12 nerve, you have 2 possibilities. Or the 12 nerve has been already damaged by chordoma, or maybe you can damage that when drilling skull base and drilling the condylar area. We also do monitoring, including, of course, lower cranial nerves and hypoglossal nerve. And sometimes you may have some postoperative impairment. But basically, it's not because of the approach, because the approach is, from the bony area point of view, is very conservative. You follow the tumor and drill around, trying to have the removal as radical as possible. That, as we all know, in chordoma is something chimeric. Very seldom you can have the sensation you have removed 100% until the very last neoplastic cell, due to the invasion around the tumor. So postoperative morbidity, add morbidity regarding hypoglossal nerve is not a major concern.
Thank you very much. Ek?
Yeah, I just want to ask about your experience with unilateral fixation of the occiput to C1 or C2. I was a little worried about torque. Did you have any patients where you decided maybe bone quality wasn't so good to do a second stage OC fusion that reaches down further? Because I think torque on a single screw may be a bit hard in a pathological case.
Well, what we have to do, what we try to do is just the fixation, and also we try to go to, this is some area where you can have, let's say, appropriate surface for further spontaneous bony fusion. So we try to put bone around. The metallic device is something that is holding the CBJ for a while, but you have to trust in bony fusion later on by means of autologous bone and also some bone promoters. But I have to mention, I didn't speak about everything. We now have a major concern. We sent almost all patients are sent to proton beam therapy after removal. And hardware is a big problem. Thus far, we have been, following the policy of trying not to put anything until the patient has been irradiated. We put the bone, we put some sort of aggressive let's say, external fixation, not craniothoracic fixation, but let's say something like orthesis, with the hope of getting some fusion months after. After finishing proton beam therapy or whatever modality of radiotherapy, we recheck the patient in terms of instability, just to see whether the patient has to be fused or not. Because we have had several patients that after operation, after removal, and after deep fixation, the patient, we have proton beam therapy in Spain since months ago. I mean, before that, we have to send the patient abroad to France or Italy or Switzerland, and the patient sometimes have been sent back. So we take that into account for making. And what we have seen is that, fortunately,
I think this
alignment,
losing you there. Miguel, it looks like we have some sort of internet problem in Malaga. So I'm sorry to sort of stop you in the middle of a sentence. I think with the interest of time, we'll move on. I wonder whether Sebastian's ready?
Yes, I am.
Brilliant. So moving on from the southernmost part of Europe to more north to Paris, I'd like to introduce to you Professor Sebastian Fröhlich, who, as everybody knows, is a wizard of the skull base, and he's going to talk to us today about the craniocervical junction.
Okay. Do you see me? Do you see my presentation on my screen?
We see your screen, we see your presentation. All we need to is maximize it, and off it goes.
Okay. So,
perfect.
hello everybody, and thank you very much for the opportunity. It's really nice to be able to share things with you guys, especially after this difficult period that we went through. So, topic of my lecture is the approach to the craniocervical junction tumors. It's a big topic because there is multiple approaches. I will try to make a kind of overview of the three main ones I am using, which are endoscopic, endonasal, posterolateral, anterolateral. So this is a cartoon just to show and to classify this approach. Here is the foramen magnum. You see the vertebral artery below it. So the most simple one is the posterior approach, but at the level of the craniocervical junction, in fact, it's not an approach that we are using so often. It's more for intradural lesions. We have the posterolateral far lateral, where we can eventually drill part of the condyle to have a more anterior access. We have the anterolateral approach, which was designed by Bernard Georges, my mentor. And we have the endoscopic endonasal approach, and we had some great cases shown by Miguel just a few minutes ago. So what pathology are we talking about? For intradural lesions, the most frequent one at this level, it's schwannoma and meningioma. We have also vascular lesions, paica-aneresis, for example, but it's not so often, especially in France. Extradural lesions, the most frequent one we are treating is chordoma. We have quite big numbers of chordoma. Others type of tumor are more anecdotal. It's more unusual. So if we look at which approach for which type of lesions, the far lateral, posterolateral approach is used mainly for intradural lesions. You can go to the lower clivus to C2. It's great for foramen magnum, meningioma, or schwannoma, or aneurysm. Anterolateral approach, we will see it after. It's an approach mainly for extradural lesions, sometimes with intradural invasion, but it's for bone lesions that are involving the bone, lower clivus, lateral mass of C1, lateral mass of C2, body of C2, ondotoid process, and down to the level of C7. We also have the extended endoscopic endonasal approach. We all know that going down below C2 is not so easy. Whenever you go intradural, you have a CSF leak risk. Whenever you go laterally, it's more risky for the vessels and for the nerve. Endoscopic is a traction suction technique, so if the tumor is soft, it's definitely much easier. One of the key anatomical points in this region is the vertebral artery. You have to be aware of this anatomy. Anatomy that is variable according to the age. Sometimes you have loops in elderly patients. Sometimes the pica is originating extradurally. And most important, it varies according to the position of the head. When you turn the head for the anterolateral approach, you move away from you the transverse process of C1, and the C1, C2 segment of the vertebral artery became parallel to the posterior arch of C1. You have to be aware of it because it can be risky. You can find the vertebral artery where you are not expecting it. So the extended endonasal approach has been a fantastic tool, and we are using it now for, I would say, 15 years, even more. As you can see, our experience is mainly with chordoma, quite a big number of craniocervical junction chordoma. So with those tumors, we started definitely with endoscopic when it came out, because it's a very logical line of sight to get to the craniocervical junction, which is shown here in this diagram. So how to expose the craniocervical junction with the endoscope? When you go midline, it's quite easy. You just have to push the inferior turbinate a little bit, coagulating it a little bit to put it out of your way. And then you make an incision on the posterior mucosa. You remove this mucosa, or you do a flap. You remove some muscle, but not too much, and you get to the lesion. Whenever you have to go laterally, it's much more challenging. You have to resect part of the inferior turbinate, and it has some drawbacks to do that. You have to resect more mucosa, more muscle, especially laterally. You may have to drill the medial pterygoid plate if you want to go to the lower aspect of the camelosinus, V3, for example, condyle jugular foramen. You have to control the second genu of the ICA to be safe if you want to work below foramen lacerum for tumor extending in this area. You may have to resect the eustachian tube, but all the patients have otitis media after, and drilling the condyle may be necessary to get to this area. So much, much more challenging. What are the drawbacks of this endoscopic approach? Well, when it's going too low at the level of the craniocervical junction, you can miss part of the tumor. It's very deep, 12, 13 centimeter. You sacrifice normal tissue, mucosa, turbinate, septum, muscle, and it has some morbidity. Neurovascular structure, especially parapharyngeal ICA, is not so easy to control. The risk of CSF leak in our experience and in teams that are doing a lot of craniocervical junction chordoma is high. It's around between 15 and 20%. Tissue coverage remain an issue, even if it's not to repair or leak. You cannot leave vessels, nerve, muscle exposed without covering it. So you need bigger flaps than the traditional nasoseptal flap sometimes. And you may create postoperative instability, which means that you will need a second surgery. Sorry. So here is a case, typical case. No, just to show you that with an endoscope looking down, 30 degrees, 45 degrees, the limit of C2 going down to the ondotoid process to me is irrelevant, because if you have the good equipment, good tools, you can go lower, definitely. This is perfect case. It's midline, very easy to manage. It's a midline incision. As you can see here, you can work 1-2 nostril. You don't destroy anything in the nose. You just push the middle turbinate. You do a U flap. You push this down, and then rapidly after, you are on the tumor that you can resect easily, because most of those chordoma, very hyper T2, they are very soft. If you have a good suction, you can take it out. Especially when it's not going intradurally, it's really definitely the approach to use for those midline tumor. Reconstruction was easy. We put back the flap and with a little bit of fat, if I remember well. Looking down with a 45-degree scope, you can take this piece of tumor along the odontoid process. Quite often, chordomas at this region goes along the odontoid process. So whenever you go laterally, as I said before, there is drawbacks. Soft tissue resection increase, risk for the ICA increase, risk for the 12 nerve or 6 increase. And if you go intradurally, as I said, it's a very high rate of CSF leak still. Look at this image of the parapharyngeal ICA. There is variations. It's a very variable segment of the ICA. Look at this loop. Sometimes those loops cross the midline. So a CTA is absolutely mandatory to look at the parapharyngeal ICA. This was a big chordoma going in both condyle here with a little bit of intradural extension here, pushing slightly the brainstem. Very challenging tumor to resect endoscopically, very close to the ICA, in contact with the vertebral artery. We did this surgery a few years ago, resection of the inferior turbinate, resection of the eustachian tube. A lot of normal tissue is going into your sucker. Here it was drilling the condyle, getting to the hypoglossal canal. It's a very nice, because it's a challenge, but for the patient postoperatively, it is not so nice. We were at the level of the vertebral artery at the end. Surgery went fine, but the recovery for this patient was quite long because of the drawbacks of all the tissues we resected to get to this tumor. In addition to that, 2 days after, she needed the fixation because she was very unstable. So the surgical footprint of those approach, velopharyngeal insufficiency, it's very often when you work in this area, just removing the tumor can create this, because you don't have this volume against the soft palate anymore. Mastication difficulties, it's quite often. And hearing impairment, and you have to remember that after you do proton beam. So all of this, the cicatrization process will be much more complicated because of the high dose radiation that will follow. So we tried to be less aggressive, to have a more preservative approach over the last 5-6 years, I would say, trying to go only one nostril. We published this technique, chopsticks technique, which means in fact that you use the corridors that you have. And if you do so, the endonasal structure are holding the instruments for you. The smallest is the space, the easiest it is, because there is nothing better than a middle turbinate, inferior turbinate to hold your instruments. So this is what we do now for those lesions. We try to go one nostril to keep the structure intact. This is a pictures of the instruments we use. It's extremely simple. It needs to be rotative on my label, your suction. It's absolutely mandatory. And this is a typical case for which we use this technique. It was one nostril. I don't remember exactly, but I think we didn't resect the middle turbinate. It seems huge, but we have 30 degree, 45 degrees, 70 degree endoscope. We have my label instruments. We have curved instruments. And this is what we did in this case. We were able to manage this tumor just with angle instrumentation. We make an incision in the rostral mucosa, and then we work through this space, just through this incision. What is the advantage? The advantage is at the end, if you remove the mucosa of the sphenoid sinus, you can put a big piece of fat in the sphenoid sinus in the tumor cavity, and then you can suture this mucosa, just like you would suture the skin if you do an open approach. So we are trying to develop those strategies. We have a curved drill, as you can see here. This rotative suction, I would not be able to do anything of this without these instruments. And you can see here that we have a very nice view of the carotid petrous segment of the ICA, lacerum segment, cavernous sinus segment. We are back at the level of the vertical segment of the petrous ICA. This is one nostril, but angle instrument. At the end, this is the skin in the mucosa opening. We put fat and we did stitches to close the mucosa over this fat. If you don't do that, your fat will disappear very, very, very rapidly. Stitching is a little bit painful, but it's just a question of time and struggling, but it's okay. So this is a post-op MRI with this fat replacing the tumor. So a few words about the posterolateral approach, which is most likely the easiest one. What I prefer is 3/4 prone with a hockey stick incision because I like to mobilize this muscle and skin inferiorly, not only laterally. So I finish my incision at the level of the tip of the mastoid process. There is other options like the one used by Helmut Bertalanffy, for example. It's very nice, but according to the indication I have for these lesions, I prefer hockey stick. So muscle in one layer. Be careful with the bovie around C1 because of those loops of the vertebral artery, especially in elderly. Then you make a craniotomy and you drill the bone towards the condyle. You don't need to drill the condyle. You just need to flatten the dura when you retract it. If there is a bulging of the dura, it means that you didn't drill enough bone before the condyle. Sometimes, quite rarely in fact, for intradural lesions, you may drill additional bone depending on the location, but for meningioma, which is one of the main indications of this approach, the tumor creates a working space. The only thing you have to do is to cut the dentate to free the brainstem. Like this, you gain some flexibility, but the tumor has made the space you need, and there is no need to drill the condyle anymore. This is a case of chordoma. It's different. We are talking now about a bone tumor. So in this chordoma case, the tumor is infiltrating the bone condyle, lateral mass of C1, a little bit of C2. It's going intradurally, and there is some tight adherences here to cerebellum and brainstem. I don't feel comfortable doing this endoscopically because of the rate of CSF leak, because of the difficult control of the pica here, because of the infiltration of the brain. You see that there was contrast enhancement here, which means subpial feeders of this part of the tumor. So what we did is a posterolateral transcondylar approach, and then we put the endoscope inside, and then we go on the other side, we go above, we go down to resect the rest of the tumor. This is a video of it. I go a little bit fast. You see the fracture of the condyle. We did a mastoidectomy here to get control of the jugular foramen also. Identifying it with Doppler, and then you debulk the tumor. It's an easy tumor to remove because it's soft. And we drill here the lower clivus. We get control of the prevertebral part of the tumor here. This is the pharyngeal muscles. And then we need to go up. To go up, we put the endoscope 45 degrees, sometimes 70 degrees, and we drill towards the petrous apex. And we get to the petrous ICA from below. We get to the sphenoid sinus from below. This is petrous ICA, level of lacerum segment. And this is the sphenoid sinus here. And then, once we have done that, there is still a piece of tumor remaining intradurally. We take it out like classic way for neurosurgeons, by manual dissection. Infiltration of the nerve are managed much more easily with the microscope than with the endoscope. And the advantage is that you can completely resect the dura mater. So resection was very nice. And we did the fixation at the same time, which we could not have done with endoscopic endonasal approach. This is another case, huge tumor, but this tumor is a big mass. So once you get into it, whatever is the entry point, the nose or the condyle, you use your endoscope and you resect most of it with your suction. So we did the same. We did a transcondylar approach, get to the tumor with the microscope. And when you reach the limit of the microscope, you put your endoscope inside and you work above, contralaterally, and below. The only thing you need here in a case like this is to understand what you are looking at, which means looking at the vertebral artery from the opposite side. So we had a fellow, Ariana Fava, who did some work in the lab, looking at the anatomy of the vertebral artery coming from the other side, because this is a risk of it. If you have a vertebral artery which is already at risk homolaterally, and you get to the vertebral artery on the opposite side, then you need to be careful. So we did this anatomical work to look at the vertebral artery, to understand how to get to it, drilling the transverse foramen from medial to lateral, finding landmarks to not being lost in those cases. I skipped the video because I'm running a little bit late. And here is a post-op MRI. So finally, the anterolateral approach. Anterolateral approach was made by Bernard Georges, my mentor. Again, he taught me this approach. You access from one side to the other. So you have access first to the vertebral artery, and then you have a free way to the bone. Lateral mass of C1, condyle, lateral mass of C2, ondotoid process, contralateral mass of C1, contralateral mass of C2. The risk is same as before, the vertebral artery on the other side. Oops, this was not supposed to be there. So a la positioning, it's a supine position. You rotate the head, but remember that the more you rotate, the more the anterior arch of C1 disappears. Slight extension. You modify the relationship of the vertebral artery C1, C2 with the bone. This is extremely important to understand. This is the position. The incision is in front of the sternocleidomastoidean muscle. Then you cut the sternocleidomastoidean muscle and the longissimus. You retract it posteriorly. You identify transverse process of C1 with your finger 1 centimeter below the tip of the mastoid. And then you find 11th nerve into the fat. You need monitoring or at least mechanical stimulation to find it. This is a dissection of it. It's typically an approach that you need to practice in the lab before, but it's a beautiful dissection. Then you find the jugular vein, you find the 10, you find the 12, you follow the posterior edge of the digastric down, you identify 11, as I said, and then you have everything. Here is 11, here is the jugular vein, carotid, 10, 12, here transverse process of C1, suboccipital triangle is here. You can resect all this fat above to retract 11 down if you need to reach the craniocervical junction. So this is the same. Once you have the suboccipital triangle with the muscle attaching on the transverse process of C1, superior oblique, inferior oblique, levator scapulae, you resect all those muscles from the transverse process of C1, and then you expose the transverse process of C1. You can open the foramen, you can mobilize the vertebral artery, form it, and transpose it, which open a door to the lateral mass of C1 and condyle. This is here the exposition of the vertebral artery and its transposition. Remember that this need to be superiostal. You cannot see the wall of the artery because if you do so, it means that you will have first a huge venous bleeding. So you need to keep the periostal sheath around the vertebral artery. Gentle manipulation of the vertebral artery, because if you're too rough, you can create a dissection of the vertebral artery. This is dissection from another research fellow, Davide, beautiful dissection showing those big plexuses around the vertebral artery that you need to keep intact. This is after transposition, you have access to the joint. You don't need to transpose like this to have access to the condyle, but you need to transpose if you want to have access to the joint and to the lateral mass of C1. Then you can work below hypoglossal canal, but also above hypoglossal canal. This was his work in the lab, the two windows above and below hypoglossal canal. These windows are used to go in the clivus. You can reach with this corridor the upper clivus, sphenoid sinus, sella, contralateral petrosiciae, difficult homolaterally because you're not ascending enough. Easy to get to the jugular foramen with this approach. You just need to do a mastoidectomy and you get to the jugular foramen from below, which is the approach we used mostly for jugular foramen tumor going into the neck. So mastoidectomy, and then you go up to the jugular foramen. I finish with one case. This is a case of chordoma again with intradural extension. You see that the long axis of the tumor is from one side to the other. There is also kind of encasement here of the vertebral artery intradurally. I didn't feel comfortable again going endoscopically. And I knew that with the drilling, I would have anyway to stabilize this patient postoperatively. So I used the anterolateral approach, same principles than before, open approach, and then the endoscope to push the limit of your corridor. This is here the incision that we used in this patient. You detach here the sterno, you find the jugular, you detach the digastric muscle, you push it down. The more you need to go up in the clivus, the more you need to detach digastric. Also, if you need to go in the jugular foramen. This is transverse process of C1. You detach the muscle, superior oblique, inferior oblique, levator scapulae. You identify vertebral artery after opening the transverse foramen. You transpose the vertebral artery. You just make sure that it's still open. Here, I needed to really push the limit up. So I just identify the jugular foramen by some drilling of the mastoid. This is the tumor. Tumor resection is easy because it's soft. It's most of the chordoma are easy to remove. The difficult part here was intradurally. So I wanted to have some control of the intradural part, and it was not inviting, but it was in between the vessels, in between the nerves. So I was happy to do that with the microscope. And at the end, I put the endoscope inside just to make sure that I have control of everything, that I am not missing a piece. And here is the spinal cord seen from above with a 45-degree scope, the spinal canal with the nerve root. And you can see the opposite side. And look here, there is this little piece of tumor just medial to the contralateral jugular foramen. And this, I probably would have missed it with the microscope. And I probably would have missed it also using the endoscope from the nose, because it's really in the dark corner of the endoscopic endonasal approach. Closure with fat. Fat is the best sealant ever. And this was it. At the end, we stabilized, like Miguel said it, with cement, because we want to try to avoid fixation, because fixation make proton beam therapy difficult. So here we put some cement between C1 lateral mass and the mastoid cavity. This was another case where we did the same. I skip it. We put a big piece of cement between the upper clivus and what was remaining of C2. And this was to avoid a fixation, which is really a pain for the radiation oncologist to do radiation. So we put this piece of cement with a collar, they do proton beam, and then after we do fixation in the vast majority of cases, either because of obvious instability or because of pain after proton beam therapy. So thank you very much. Thanks to my team and my fellows who are helping me a lot with those research on new technique. Thank you very much.
Thank you very much. Thank you for the very exhaustive talk. We covered a lot of ground. In the interest of time, I think we'll have to move on. It's a great pleasure to introduce Dr. Sanjeeva Jayarathna, a very good friend of mine based in Oxford, so we've crossed the English Channel now. And Sanjeev, although he works in Oxford, he partially lives in Cambridge, and we sometimes share our Cambridge laboratory. In fact, we have a session organized for in 2 weeks' time, but I believe he's ready, and he has very interesting program ready for us today. He will introduce us to it himself. Sanjeev.
Tom, thank you for the kind introduction. Right, so my talk is going to be a little bit different to everybody else. As you know, we're always trying to make the program better, and Emad, Vlad, very keen to try something different. And what we really want to do here is we want to make it very interactive. So I'm particularly keen that the 300 something people who are on Zoom join us. I'm going to ask the faculty to join in as well. I'll explain how that's going to work. And we're going to try and bring the people on YouTube, neurosurgical TV, being broadcast in Japan and China along, but I know there's a bit of a delay. So this could be a little bit difficult to do that, but I'm going to try, okay? So
we have a little experiment here.
Indeed. Now, I need to advance my slide. Okay, so there are going to be questions as we go along. And what I'm going to need, and this is the first question, so we're going to start off nice and easy, but I want everybody to log in. Now, the key is don't lose your Zoom browser. That is the key bit, okay? So don't lose the Zoom browser. What I want you to do is to get an extra tab. I'm going to do it on my phone, and I want you to go to this web address, www.menti.com, and put in that code. So I'm going to do that on my phone. Can I ask the faculty to go in as well and go to that web address? And I'm going to ask everyone, don't lose your Zoom browser. Okay, I want you to, some people are already on quickly. Everybody on Zoom, everybody on the YouTube channel, I know there's a delay there. Please log on to this one on a separate page, in a separate tab, on a separate device, and tell us where you're from. Now, are the faculty all logged in?
Yes.
Yeah. Dr. Gonzalez, good. Emad, are you on? I'm going to fill in the question as well. Now, given the hundreds of people who are joining this presentation, we're very keen to see hundreds of responses. I know there's a delay on YouTube and all of that. Roy, are all your residents logged in? Anybody have any questions from the faculty about how this works?
Oh, Asia is winning now.
Asia is winning.
Yeah, pressing a button.
It's one of those COVID statistics.
Yes. Sorry, where do you click to?
So you're going to go to this website. Don't lose the Zoom browser. You're going to go to this website, and you're going to put in this code.
In fact, you have to use your phone or some other device.
Phone, or you open a new tab on one of your browsers. But if you have a phone, you're watching this on your computer, try on a different device.
So Asia is doing.
Come on, people from Europe. Asia is winning.
I know. What's going on? Sebastian, have you logged in?
No hope now.
I am logged in. I am logged in.
Vote, Sebastian, vote.
North America.
I think it's Asia against the rest of the world, yeah?
Okay, so we're getting up to 100 votes. So this is how it's going to work. We're going to have questions going forward. So we'd like to see everybody log in. I know there's a delay on YouTube and maybe a delay in China and Japan on neurosurgical TV. But everybody on Zoom, there's 362 I see. Everybody on Zoom, get a separate browser, go on a separate device, and then I want you to vote. Okay? So this is how it's going to work. Good. All right, so stop it there. Yeah, Asia is in the lead. All right, excellent. So we're going to move forward. No, letting me move forward. Okay. Right, so I've picked 3 cases. We've had 4 days now of this seminar, so I've picked 3 cases. One is, I picked them for specific reasons. One is a case that's been a type of, a bit of anatomy that's been discussed in great detail. So let's see how much you've been taking in. One is to introduce a slightly different area of anatomy, just to bring that up briefly. And another one is just something I talked about before, and we've seen different ideas since then. So we'll talk about that as well. So that's the plan for today. We're going to have 3 cases that we go through, but people are going to vote, and you're going to tell me what you're going to do, what the anatomy is, and all of that. And let's see how we get on. Okay? So let's start with the posterior fossa mass. Okay, so 68-year-old gentleman. He comes in with progressive worsening of balance and gait and headaches. And these are his scans, all right? So I'm just going to talk you through the scans, obviously all axial cuts. This is a T2 scan showing that one there. This is a flare sequence. So you can see the mass suppresses on flare. And then we've got restricted diffusion here on the DWI scans, all right? So that's what we've got, the information you've got so far. So we're going to go to the first question. These are the options you're about to see, and I'm going to ask, what is the diagnosis? All right. So everybody, I'm going to vote. Everybody should be able to vote. Oh, we got an early win for epidermoid. Anybody else? Anybody else feel this is a cystic vestibular schwannoma? Anything else? Yeah, subependymoma coming up. Okay, we've got some epidermoid is winning hands down at the moment. So let's ask some of the panelists maybe. Tom, you want to comment on those scans you saw earlier? What are your thoughts?
Yeah, so kind of the location and distribution and your strong suggestion of the restricted diffusion, although not the most typical I've seen, is consistent with epidermoid, but yeah, could potentially be other things as well.
Okay, so we also thought this was most like an epidermoid, so I agree with the...
I have to add one more thing.
Yes, Imad,
the lesion, this size of a lesion in this age group, it by clinical appearance, clinical presentation is close against malignant type of tumors.
Yes,
because he is not bad clinically in the sense.
Yes, that's right. It's pretty good.
So it's added to the diffusion issue.
Sorry, what was the comment on diffusion?
No, it adds to Tom's description that there is a restriction of diffusion, which is in support of epidermoid.
Yes, I agree. And we also thought it was an epidermoid. Now, we've only got 120 people logged in of the 300 something, so I'd like to encourage all these people, all of you to log in, those 300 something people on Zoom, and everybody else in Asia, please do log in to this website. That is the code. We're very keen to hear from you on what you think is going on with these cases. So, okay, we believe this is an epidermoid. He's got significant mass effect, symptoms. So we have to try and decide what we're going to do. And of course, this is the neuroanatomy lecture, so we're very keen to first, well, we're considering surgery here. So the first thing, of course, is what is the location? So take your time, have a look at these pictures. Here, of course, is the mass again there. Here is a sagittal T1 with contrast, and you can see there's no real contrast enhancement in the mass, which should again be going with an epidermoid. So the question is going to be, what do you think? What is the location of this lesion? All right, and here are the options that I've given. Oh, CP angle, a close fight between CP angle and, oh no, sorry, Lushka is winning. Lushka's winning big. Okay, so while that's going on, I suppose the question about where this is relates to the surgery a little bit, doesn't it? Ek, you spoke earlier about this. What are your thoughts on it?
I would have said from Lushka is rather similar to the case that I showed at the end. I think there's a portion that is protruding out into the lateral, junction of the medulla and the cerebellum, and there's a portion that reaches in medially. So it's sort of centered right at the outflow of fourth ventricle laterally.
Yeah, okay. Anybody else have any views on this? Lushka is winning. Some people have said CP angle. Anyone else from the panel has a view on this? A different view than foramen of Lushka? No, okay. So we're all fairly uniform on this. We can see that Lushka is winning hands down here nicely. It does have, of course, components of it within the fourth ventricle and the CP angle, doesn't it? All right, so we've sort of decided where this is. But there are some important points. It is, as we've described, a very sizable epidermal. I've just got some arrows here. I'll explain the first arrow. I just want to show that it goes up right to the 7th and 8th cranial nerves, as you'd expect of something coming out of the foramen of Lushka. And then you have to sort of understand if we're going to operate on this. We've worked out the location. It's at Lushka, so within the fourth and CP angle as well, as you'd expect. But then you have to start to work out what are these flow voids here. So they are clearly blood vessels, and they form an important part of the anatomy that you have to understand when you're going to operate on something like this. And Tom and Echo have been talking about this in the previous seminar and this one. So the next question, of course, is...
Can I ask a question to Sanjeeva?
Becky, yes.
The primary question is it intra-axial or extra-axial?
Ah, yes, that's a good point.
Very basic question.
Yes. Okay, Keki, what do you think? Intra or extra-axial?
It is intra-extra-axial.
Yeah, I think in general, epidermoid is a cisternal lesion. But there are intraventricular components, but it gives a different irritation system. But they are cisternal lesion in generally in that CP angle area. Okay. And it's easy to communicate through the Lushka.
Yes, yes. Now, when you come to operate on it though, Kiki, what do you think about it? It's a difference, isn't it, how you operate on intra and extra-axial lesion? The techniques are slightly different, aren't they, Kiki? What are your thoughts on that?
I think, if you ask me, this could be approached by just...
No, approach is later, Kiki. That's coming later.
Okay.
Discuss that at the moment. That's coming.
What was your question?
So when there's intra-extra-axial, then the dissection techniques, are you purely arachnoidal? Are you working within?
Yeah, then I think, we just heard a very nice presentation, Telo-vela.
That's again approaches, so we'll come to that later. Okay, well, maybe we'll come back to the discussion a bit later. Okay, so the lesion is filling, the fourth ventricle, but as we discussed through Lushka and also in the CP angle. And before we decide how we're going to operate on this, and there are a number of different options you could consider, you have to understand a bit of the anatomy, don't we? And so the next question has to do with these two blood vessels, which are flow voids there. So the question is, and you've seen lots of talks about this, what structures are shown by the red arrow? So we're all going to vote. Paika's off to an early lead there. So let's see what people think. We got 6 people onto the ICA. And so this is in tumors in this location, particularly in that bit there in the fourth ventricle. Of course, the critical bit of anatomy to understand is the pica, and for some of these questions, there's no right or wrong answer here. There is a right answer. It is the pica, clearly, that we're seeing there. Okay, and we'll talk about the segments of the pica now. So this is in a minute. So the next question is, what approach will you employ? And Kiki mentioned one of the options, but I've given a number of different options there. So, we said it was a CP angle, what some people consider a retrosigmoid approach. We heard people discuss the transvermian. Would you go right through the cerebellum? Part of this, I think, depends on your skill level in what you're comfortable with doing. So I don't want to say there's a right or wrong approach. Of course, we would all favor approach. There's one approach that I favored, which I used in this case. All right, so this is interesting. We've got about 30 people saying retrosigmoid. Imad, you gave a nice talk on retrosigmoid last time. What are your thoughts on using the retrosigmoid approach for this case?
First, I'll go completely extra-axial.
I agree.
Since that lesion going around the entry area of the facial 8th nerve complex, I want to make sure I'm not working blind there. And the other things, I feel I'm a proponent, a supporter of the hybrid approach with the endoscope. So I can still use the endoscope from that area that coming more medially to take the last bit. Epidermoid, I used what it was mentioned for the chordoma, the application of chopstick technique here. In general, epidermoid is an avascular lesion. And the vessels inside, we call them the hanging vessels because they are not displaced but encased, but is easy to dissect from. So this is my choice. And there is always an option for a combination. I mean, you cannot be stick to one. Sometimes you find that angle is not adequate, but there is the wide base extension of that lesion along the posterior petrous, and I feel from the CP angle I have a good component to remove rather than to do anything through the cerebellum.
Okay, so you would favor the retrosigmoid approach. Okay, interesting. Now, Kawase, I'm sorry, and far lateral, I don't think these are particularly good options. The far lateral really is for something lower down, Kawase for much higher. So I'm sorry, I don't think those are particularly good approaches for this case. Of course, there may be differing opinions. We had a long discussion about going transvermian. You could even consider transcerebral. I think that really depends on your what you're comfortable doing. You have to do what's safe for the patient. As a skull-based surgeon, I really dislike breaching the cortex anyway. So I would be looking for one of those two approaches. Anybody who feels the Telo-vela is a good approach from the panel?
Yeah, I would do a Telo-vela.
Why is that, Ramesh? We just discussed how it's going to the CP angle.
Yeah, I know. But your one of the primary aims is to make sure that you don't injure the pica, which are quite medial and shifted to one side. And and also with the Telo-vela approach, once you get a good elevation of the tonsil, you are able to follow this epidermoid into any crevices that it may follow. And all you need, and also you're not traversing any neural plane. You are within the tumor, and you can get with endoscope, additional endoscope to the lateral CP angle position. You can get extensive resection of all these tumors.
Yes, I agree, and that is the approach I chose. Actually, I went for, although I do a lot of retrosigmoids for acoustics and things. Actually, I went. Sorry, somebody's saying something.
Sanjeeva.
Yes, Vlad. Yes.
Yeah. There is a combination. I would do a far lateral or infralateral approach and then Telo-vela, unilateral Telo-vela. I would lift only the ipsilateral tonsil, and you get to the whole posterior part of the lesion. You get to the CP angle easily. You get easily to the fourth ventricle by this approach. Far lateral plus Telo-vela.
Okay,
but can I just make a comment, Sanjeeva?
Let's go back and look at the pictures while we're talking. Yeah.
Yeah, Vlad, I mean, I know, why do you want to do a far lateral and do a lot of bony resection for the epidermoid? For the epidermoid, the decision's already been done. All you need to do is to go inside the tumor and
not that much. I'm not talking about far lateral as it is described. I would do it like a enough lateral,
Oh, yeah, I got it.
Yeah, with no condyle resection at all, because you will do all your work above the condyle, so you do not need to resect it. Not much work.
Yeah. Well, I think this brings me nicely to my point that you should do what you feel comfortable, what is safe in your hands. So we've heard some very experienced surgeons. So Imad has talked about coming retrosigmoid. Vlad is talking about doing a far lateral combined with Telo-vela. I actually agree with Ramesh, and that's what I did.
Can I join Sanjeev? Yes. I actually would probably, and most people as well would in practice do. Pretty much do what Vladimir said, yeah? Often we think of certain approaches in isolation, but you basically do, enough approach to be able to gauge it. So you can do sort of not midline, but off midline, but lateral enough to have enough lateral approach for the anterior part of the tumor and have complete control over it. I've done a few of those, and it was kind of combined, sort of off midline and lateral enough approach. So
yeah, no, I think it's very reasonable, and these are all very good suggestions. Unfortunately, because of this file limit on this website I'm using, I can't show you the video. But actually, you can comment also view the CP angle through a Telo-vela, as I'll show some.
I think Sebastian, you got some comment.
Sebastian,
do you hear me?
Yes, we can. Sebastian, go on.
Yes, me, I have to say that I think I would be also in favor of a far lateral, not with condyle drilling as it was said, but the advantage here with this kind of approach is to have the midline access, to have the Telo-vela access, to have the retrosig access. The goal in a lesion like this is not to resect what's inside the epidermoid cyst. If it's not a recurrence, the goal is to try to resect the capsule, and that's the only way to cure those patients.
Yes.
And if I remember well, she's quite young. So it makes sense to try to achieve a complete resection, and for this to have multiple line of sight, multiple angle to dissect each cranial nerve, each vessels, and to remove the capsule from it is nice.
Yeah, so,
so
I have to interfere here a little bit.
No problem.
May I? May I?
Of course, of course. That's the whole point of this.
I think the age of the patient, I think in his late 60, how old is he? This age group, I'm not going to take the capsule from that lesion completely.
Okay.
You will ask for trouble, especially seeing these voids as well. In general, epidermoid is nice to dissect, but when it comes to capsule, I don't reinforce it in this age group. They can live with the residual 13 years without any problems. And you can always operate second time on these people without any major problem. So I won't be very aggressive regarding the capsule. I resect whatever is easy in front of me to resect a capsule, but if it's adherent, I will leave it.
Yes, I think it's very adherent you should leave, and that's actually what I did here, although the vast majority of it came out. Okay.
But the age of the recurrence is dependent on the amount of capsule you remove.
Yes.
So I would not necessarily remove
volume, isn't
the
it?
capsule. But if you just empty the cyst with leaving the capsule like it is, it will not come back in 30 years. It will come back much earlier than this. I agree that you could go back with a simple approach, but so can lose.
Sorry, I said to resect as much of the capsule that is easy to dissect. But if it's adherent, don't enforce it.
Yeah, so you can see here there's a number of different approaches, and I suspect we may be roughly talking about the same thing if we actually watched each other's videos. But what we're advocating is as extensive a resection as possible that is safe to do. And we've had two very senior surgeons suggest a sort of far lateral position, which will give you access around both sides of the tonsil, which is interesting. I actually went for a pure Telo-vela approach and had a sort of nice view of this. And just for our more junior colleagues who are joining us on this webinar, I'm just showing a view from the side of the brainstem and the cerebellum. And of course, these Roton pictures are all available online for free now, and I encourage you to view them. And we're going to start looking here at the anterolateral segments, but the important segments involved in resecting, particularly in the Telo-vela approach, is understanding how the pica comes around the tonsil, and then the tonsillomedullary and Telo-vela segments of the pica, which is shown here. And there's some important anatomy to understand if you're going to use a pure Telo-vela approach to resect this. But as you heard, there are a number of other options here. So just to orientate you, this is the foramen of Magendie. You're watching the pica come up, and then you have its medial and lateral branches. This is the tela choroidea. This is the tonsil being lifted up. So the first, and this is earlier you heard about sort of Berman-Smith, which, as I said, the skull-base surgeon I'm not in favor of, but I understand may be used sometimes, and we heard can be safe. But my next question is to some of our more junior colleagues. I know the senior panelists will clearly understand this anatomy very well, but to everyone, what is this area here that I'm pointing to with the yellow arrow? So, what is shown by the yellow arrow? Please. Alushka's off to an early win here. Anybody want to go for seventh nerve? Okay. Well, seventh nerve is close to the foramen of Alushka. I think you'd agree while the voting is going on, Sebastian and Emad, that we're essentially saying a similar things, that we would resect as much as is safely possible. We'd take as much capsule as we could get. Do you agree with that?
I think what maybe everyone really, everyone from their point of view, but what kind of Vladimir started talking, and I joined in later on with him. It was that the more angle of view and comfortable work you have, particularly on the delicate structures, vascular structures in particular, the more safely you'll be able to resect. So that's why going kind of directly forward into the fourth ventricle, but also from more lateral, so as you can view all the structures more anteriorly to the brainstem, you know, it would be just helpful, and it's not such a big deal to achieve that.
Yeah. So you're quite right. This is, of course, the foramen of Luschka, and this is the point I think Ramesh made right at the beginning, which I agree with fully, is that when you start coagulating and cutting, and of course this is all very stretched, isn't it? You've got a very large tumor here. In some ways that makes it much easier for you. And we've used this approach a few times to really get nicely into the CP angle. And I said I really like the retrosigmoid far lateral. I use that a lot for meningiomas, vestibular schwannomas. But actually, as you start, particularly in large tumors, as you coagulate and you start cutting around, you can open it nicely into Luschka, and you have an absolutely fantastic view right up to the root entry zone of 7. Beyond that, of course, it is very, you're limited by the nerves coming into the brainstem. But up to that point, even with some ependymomas, you get an absolutely fantastic view. But as you heard here, there's lots of different approaches that you could take to do this very safely and nicely. But one of them is a pure Telo-vela. And this is just another view, just to explain that, showing how you working. This is the velum here, telechoroidea, how you can get out nicely into the lateral recesses of the fourth ventricle just by following that out. Okay, and so I just want to reinforce that when you see these sort of pictures, you have to remember the anatomy of how you can follow outwards. You have to understand where the pica is. You have to understand where 7 and 8 are going to come, and what you can do via a Telo-vela approach. Now, I just have one last question, because the other thing to remember, of course, is not just 7 and 8 and things that you can injure. There are other structures that theoretically you can harm. And I'm going to ask what is highlighted here in yellow. So we're looking from the back to show you again. You got the tonsil, pica, velum is here. This is the top of the tonsil with some of the pica vessels there. Vessels coming off the SCA from the top of the cerebellum coming to supply this structure. And this is another structure. You have to be careful as you're working out into Luschka not to injure. And also relates to some of the things we discussed earlier. So what is the highlighted structure, please? Oh, people are rushing off with the dentate nucleus. Anybody have any other? Yeah, we've got some of the peduncle. Any other advances on the dentate nucleus? Well, in the interest of time, that's very good. I'm going to move forward. That is the correct answer. We're looking at the dentate nucleus there. Okay, good. So, these are just the post-op scans just to show the craniotomy here. You got a very nice resection with almost nothing that you can see on the post-op MRI scan. I knew, of course, that I left very tiny bits where it was very stuck down. But actually, the vast majority can be resected very nicely through this approach or something like that. Sorry?
Just one brief comment.
Yes.
One brief comment is that a lot depends upon what approach you will take. The bone work will depend upon what approach you take. And therefore, it's very important to be clear in your mind what approach you want to take, because you can't switch from a far lateral to a Telo-vela and vice versa. And
the position will be different as well.
And Sanjeeva, I think that goes to show with the epidermoid, even if you go minimalistic approach, rather trying to do a big approach, you can remove most of it. And that's Imad said, elderly patients, I wouldn't try to take the capsule off the lower cranial nerves.
Yes, I think it comes off easily. But I agree. No, it's very, very stuck down. This one actually.
I have one comment on the images. I think because I reviewed that subject, and I'm sure you all of you reviewed this subject, comparison of results cannot be done without having diffusion images post-op.
No, you're correct. You must have the diffusion images.
Otherwise, many people, they have claimed in the old publication complete resection and without diffusion images. Without diffusion images, you cannot claim complete resection.
So actually,
a very important point.
I think there's an important point here, Imad, that, so for example, I think this may have been reported, I can bring up the diffusion images. I think it may have been reported as a complete resection based on diffusion, but actually the resolution of diffusion is not that good. So I knew I had left very tiny bits left behind in this case, but it was below the resolution of diffusion imaging, which is not as high as some of the other ones. But I agree with you. I should put a diffusion picture in here.
No, I'm not criticizing you because you put T2. I'm just saying in publication, people want to compare their results and claim complete resection. They have to show diffusion image to have a same currency for comparison.
I agree. But you can see that, mass effect and all of that is gone. But you're absolutely right. Diffusion is the most sensitive bit. And
I would have one comment too. There is usually not only one approach to the lesions. So if someone would choose retrosig, it's okay as long as far as the job was done. If you do the Telo-vela, that's okay. So this is about the approach. Whoever chooses the one with which he is most comfortable and able to do the job is just all right.
I agree 100% with that.
I think this is the message we have to give to the young neurosurgeons. They should not stick to one, and there are different good approaches to that lesion, and there is nothing wrong by having more than one approach to one lesion.
Yes, absolutely.
You cannot single it out by having everything all inclusive and by one lesion, one approach.
Absolutely, I agree. And then you should be able to do all of them and pick what is best.
But also one sort of overriding theme as well is don't restrict yourself too much too early unless you absolutely know that you can manage from the restricted approach. So
yes,
don't be a hero too early, or try to see that you can do something with closed eyes and with one eye and things like that.
Yeah, absolutely. Okay, let's move on to the next one. So this is a retired nurse. She has some numbness, mainly in the V2 distribution. She's got a history of previous Hodgkin's lymphoma, and she's got a right-sided mass in the sinuses. All right, so this is the mass here. So you've got a T1 image here. This is fat SAT, obviously, post-GAD lesion. This obviously is the maxillary sinus in the front there. So the first question I have for everybody is, where is this mass? Do you think it's infratemporal fossa, nasopharynx, orbit, pterygopalatine fossa, or temporal lobe?
You couldn't show us that picture again, would you, Sanjeev?
Sorry. This is the mass. Okay.
Thanks.
I'll have a good look. I'm only giving axials. And I would like to know where you think the mass is.
What do you think it is?
Okay. Good. Well, I'll just let that get up to about 100 people, and then I'll. Good. So I agree. No, I agree with the pterygopalatine fossa. I don't agree that's the infratemporal fossa. But if anybody wants to disagree, they're welcome to say. But let me just show you on the CT scan. Obviously, it's a bit hard. You only had one view, so it wasn't that easy for you to tell. We're going to discuss the borders and anatomy, so I'm not going to go into that too much, just in a minute, the pterygopalatine fossa. But if I just show you the anatomy on the normal side, show you where Vidian is, I think having the maxilla is very useful. This is where obviously where the tumor is on the other side. You've got pterygomaxillary fissure there. I think you'd all agree that the best place or the best way to describe the location of this tumor would be pterygopalatine fossa. Okay, so I'm going to move forward. So now I just want to introduce a little bit of new anatomy that we didn't cover, just to give you something new on the webinars. Now here, obviously, you can choose more than one answer. So this is different to the other ones. Okay, here you can choose more than one answer. So choose as many answers as you want. And I want to know, what are the borders of the pterygopalatine fossa? Okay, so please choose as many answers. I'm also going to answer. So please choose as many answers as you like for this. And I think it's an interesting space anatomically just to discuss and talk again about the approaches. Good, so we've got, everybody's getting the palatine bone, which is correct. That's well done, that obviously forms the medial border. Okay, I'll just, maybe I'll let another get up to about 120 and then anybody else wants to answer. I hope our colleagues on YouTube are able to join us. I know there's a lag for them, so I'll just linger a little bit on this slide to see if our YouTube colleagues can also join in, and then we'll move on. Okay, I think that's pretty good. Right, so I agree. You've quite rightly identified the borders of the pterygopalatine fossa. You have the sphenoid bone, the palatine bone, the maxilla, and the pterygomaxillary fissure are the correct answers for the borders. Okay, I showed earlier where the pterygomaxillary fissure was. You have the sphenoid superiorly and posteriorly. You've got the descending plate of the palatine bone, and of course the maxilla forms the anterior wall of the pterygopalatine fossa. All right, and then the important thing to understand, of course, is that the arteries are in front, the blood vessel, sorry, the nerves are at the back. So let's look at the pterygopalatine fossa a little bit more on one or two of the important points. The other important points, of course, to point out are the middle terminates and inferior terminates and their relationship to pterygopalatine fossa. Okay, so the next question is, what arteries are within the pterygopalatine fossa? Again, you can put as many answers as you feel are appropriate. Please put as many answers as you think are appropriate. Maybe I'll ask one of my colleagues who probably do quite a bit of endoscopy. Miguel or Sebastian, you want to make a comment on this?
If Miguel not there, I think Igor gave a nice presentation on vessels yesterday.
Igor, excellent. Igor, come on. And what are your thoughts about the answers, Igor? No, we haven't got Igor. No problem.
I'm sorry, Sanjeeva.
Igor, excellent.
I was concentrated on something else. I apologize.
No problem. Igor, we are talking about arteries within the pterygopalatine fossa. And everybody agrees the maxillary arteries within the pterygo, which is of course correct. As neurosurgeons, we are very familiar with the sphenopalatine artery, which is also correct. It is within the pterygopalatine fossa. That is correct. What are your thoughts about the pharyngeal, vidian, and rotundum?
I'm not really feeling.
Question. It's more really in the realm of ENT. So, but I think you're quite correct in saying that actually all of these arteries are within the pterygopalatine fossa. So this is a little bit of a trick question. So I'm sorry, it's a bit unfair, but these are all blood vessels or branches of the maxillary artery that are within the pterygopalatine fossa. And I see in response to that, everybody's adding a few more answers there to the other ones, so that's good. But yeah, all of these, so everybody got the maxillary artery, and a lot of people also understood the sphenopalatine that we all understand as neurosurgeons, but actually there are 7 openings in the pterygopalatine fossa. This, as you know, this is an inverted pyramid, and all of those things that I listed there are all arteries within pterygopalatine. So you get the maxillary coming in, and basically anywhere where you have a foramen, there is an artery going into it. So there'll be the sphenopalatine. There is a vidian artery, pharyngeal arteries at the back. It's not shown here. There will be an artery going to foramen rotundum. There will be an artery going up the infraorbital artery along with the infraorbital nerve, and of course the descending palatine. So actually the simple answer here is wherever you have a foramen or a nerve, there's usually an artery associated with it in the pterygopalatine fossa. Okay, so all of those answers were correct on that one. All right, so now we understand a little bit about it. The next question, of course, is how are you going to get to this mass in the pterygopalatine fossa? Early jump for the endoscopic approach here. Now, who's still here? What about Roy? You want to make a comment, Roy? Let's see who's still here on this. What are your thoughts, Roy, on Oh, no, you're too far away. You got to go to the microcam. Sorry. I should have won. Oh, okay. Some people are going for orbital zygomatic. That's interesting. What are your thoughts, Roy, on this?
Well, the endoscopic is the most elegant way to do
You have to speak up a bit more, Roy.
Well, the endoscopic approach would be the most elegant way to do it, but that doesn't mean you can't do one of the basic approaches on this. The cranial approaches are not really relevant. I would surely do an endoscopic approach.
Yeah, I agree. I agree. Anyone else have any thoughts on this? I like the one person who said radiotherapy. Very good. Any other thoughts?
Well, I mean, Sanjeev, I agree with Roy. I think this is just behind the maxillary antrum, and the pterygopalatine fossa, as you know, is easily accessible through an endoscopic approach. And when we do a transpsyrigoid approach for skull-based lesion, this is a common location we encounter. So I think any lesion can be approached very elegantly through an endoscopic approach.
Yeah, I agree fully. Now, it looks like we have some ENT colleagues here. So the Cadwell Luck, just for anybody who doesn't know what that is a, as it says here, radical antrostomy. That's where you're coming straight through the back of the front of the maxilla, which takes you nicely into the maxillary sinus, and will take you straight through the back wall, will take you to pterygopalatine fossa.
Yeah.
But I agree fully. I think this is the preferred approach. You know, you can get almost anywhere with the pterional, really, but it's this unnecessarily destructive pterional orbital, anything like that. Equally nowadays for a Cadwell Luck, although it used to be the standard way to get to this place.
Yeah, and Ana Lucia is asking, what would you do if you don't have access to an endoscope in your center?
Oh dear. Well, there are a number of options. You can refer the patient. Because if you look at it, it's quite a small tumor, isn't it? So to do a very destructive, sorry, I'm trying to move backwards. To do something quite destructive for this tumor, I think would be unnecessary, really. And you could consider referring somewhere else. There are, of course, approaches you can do, open approaches in Frontal fossa and pterygopalatine fossa. But I think
in that case, I would just, I mean, if you don't have access to endoscopic surgery, just go back to what we were doing before the endoscopes came into play.
Yeah, I mean, your ENT surgeons will be able to do a Cadwell Luck.
Yeah,
You
so
know,
that
can be done open.
Open the gingival incision, get into the maxilla, go to the posterior bottom of the maxilla, and you're there. So it is a very good approach, and it heals pretty well. So there's no facial scars either. So it is possible. Yeah.
I think the risks are slightly higher, you know, to things like the infraorbital nerve, but yeah, very reasonable. But as we discussed, endoscopic approach is beautiful through here. You open up into the open the uncinate, open the bulla ethmoidale. If you want, you can open into the anterior and posterior ethmoids, and then you're in nicely.
I think, as Sanjeev is saying and defending the intranasal approach, you know, with endoscope, you can have a smaller hole, but there was a life before endoscope, and you could actually make the hole bigger and work through it without an endoscope. So maxilla is actually a fantastic. It's a bit like transphenoidal approach to sella and so on. The maxilla is a tremendous sinus to approach the pterygopalatine fossa too.
Yeah, yeah. Not unreasonable, though we get an absolutely fantastic view nowadays coming that way.
Pablo, this is Moody.
Sorry?
Pablo, this is Moody.
Moody.
You and I have.
I'm Moody.
You and I have both worked in Zanzibar, and we have a microscope there. If we don't have an endoscope, a Cadwell Luck is just fine. You can just make an incision on the gingiva and get in there. And if you go to the image that was showing the tumor, just go back, Sanjeeva.
Yeah.
There you go. No, the mass lesion. If you look at that maxilla, you're straight in there into the tumor. And the incision for the Cadwell Luck is not more than 1.5 centimeters above you. So you can pretty much get there with a microscope and get to it. So I think the folks who asked, if you don't have an endoscope, what would you do? If you've got a microscope there, or you can get in there and have a look and get that tumor out.
Thank you. Thank you.
Okay. anything else about this one? So,
Sanjeev, I may have missed your comment about the diagnosis. What was the pathology?
oh, I never said. We thought it was a chordoma, but it came back as a malignant peripheral nerve sheath tumor, which was interesting.
Okay. All right. Yeah.
Right. Next chap, 59-year-old, getting progressive worsening of gait, some difficulty swallowing. Actually comes in with hydrocephalus and some confusion and drowsiness. And this is the scan. Okay. Right. So obviously, you know, we thought this was a petroclival meningioma. It's a true petroclival. It's medial to the trigeminal nerves. It's coming down on the clivus. But actually, the bits I want to talk about a little bit, we'll talk about petroclival, but I want to talk a little bit is the fact that it's actually also quite high. You know, it went all the way anteriorly to sort of near the uncus. So high and anterior, and also coming all the way down. So we put an external ventricular drain in, obviously as the first step, but then we wanted to deal with the main problem. Right, well, this is now ripe for discussion. What approach? Retrosig, okay.
Well, you haven't put one of the most important approaches in your options, though.
Which is?
It is the supra-infra.
Oh, sorry, that's what I mean by transpetrous transanterior, where you cut the tentorium and go in middle fossa and posterior fossa.
Why is it called transpetrous then?
Because you're taking the posterior petrosectomy, aren't you? Or you combine
No. They're talking about the supracerebellar infratentorial approach.
Oh, supracerebellar infratentorial approach. Oh, interesting. Oh, I didn't.
He meant, I think, a lateral supra-infra.
Extreme lateral supra-infra.
This is what I call it Dr. Benish.
Exactly.
Approach.
Oh, this is getting very interesting. Okay.
I know that Vladimir liked this approach.
Right. Okay. Well, this is getting very interesting. You're right. No, I didn't. It's not something I used. I didn't consider that. Okay. Right. Who's in the? Anybody on the panel? Well, Ipe, are you on this call? You have an interesting approach to these, don't you? Is Ipe on the call? No. We haven't got Ipe here. All right. Anybody on the panel would like to go retrosigmoid for this lesion?
Well, essentially the supra-infra, that is supracerebellar infratentorial approach, is an extension of the retrosigmoid. So if you can expose the transverse sigmoid junction and work above the 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 tentorial surface of the cerebellum, and use the retrosigmoid superior to the seventh nerve, that's the supra-infra extreme lateral. So yes, that's a great approach.
And would you do a middle fossa craniotomy as well, or you're just?
Not at all. I would cut the tentorium and look above.
And do you feel you go all the way anteriorly?
Oh yes, absolutely. You can go, well, if there is tumor on the other side of the clivus, that means the lateral end of the clivus, maybe it will get to be difficult. But with endoscopes, you could solve that issue as well.
I think this approach, I like it, but for that lesion, if you put the X-ray again, please. You see the lower pole of that lesion is very low.
Yes, that's essentially the limitation of the supra-infra.
Yeah, this is the limitation. If it's a little bit higher, might be a consideration, but here yes, you have to retract the cerebellum further down to reach the lower pole of that lesion.
That's why the retrosigmoid window is also used. So lesions up to the seventh nerve, eighth nerve is very easily done. Anything below that, you will have to extend further the retrosigmoid craniotomy to get access to that. And that part is difficult, I agree. But then it does not mean you have to stop with just that. That part can be accessed through another, an extension of the same approach.
Your axial view, can I have it again, the axial view?
Yeah.
The axial view showed that the amount of the lesion leaping in the subtemporal area, perhaps you didn't go further higher, yeah?
No, this is at the sort of level of 5, isn't it? This is much higher, so it goes very high.
Much higher, it's much higher. If it's only this is component, I will go for retrosigmoid and support it with endoscopy, incising the tentorium from below. This is an approach published in 1992 by Dr. Amirati and Dr. Sami, where they go from suprameatal, resect most of the tumor, and then they incise the tentorium from below to retrieve the upper one. In the recent year, we did few of these cases complemented with the endoscope, 30-degree, to retrieve the amount up. But this amount up is very huge. It's not a small one.
It is very huge.
Yeah,
Yes.
and we have to look to the blood supply of this lesion. The Casinari vessel usually is one of the major supply. If you want to take care of that one with less bleeding, you have to close that vessel at the tentorium edge. And I don't want to say what I have in my mind because you are still waiting for the vote. Once the vote is finished, and then I say what I said.
Let's get another view. Sebastian still on this call, or is he gone?
I'm in.
What would you do, Sebastian? This is the tumor. What's your approach? Hello? I think you're muted. Are you? We can't hear you, Sebastian. You know you're there.
Hello.
We lost him. Victor, did you have something to say?
Yeah, I think a combined approach is much better. For example, simple mastoidectomy, presigmoid approach, transtentorial, transpetrous. I think in this kind of approach, you can go to most of the tumor.
Yeah.
I think this is my favorite approach, the combined approach, the pre-sigmoid approach. And especially in that case, you said the hydrocephalus, this need an EVD because we want to elevate the temporal lobe on the left side. So vena blave, we have to be respected. But this is, I think, the approach that will hit the tumor from different angle.
Yes.
Yes, agree.
Now, can we hear back from Sebastian? No, he's gone. Is he? We've lost him. G Tang, you've unmuted. What do you think?
I think for this case, just I have taught that today, and for I combine, I agree with the two simple ways to resect this tumor. Two simple is means one is the subtemporal, and with the retrosigmoid approach. So
but subtemporal G, how low can you go with the subtemporal?
Subtemporal approach for this lesion, we can reach at the level at the trigeminal nerve. Okay, it will remove part of the tumor, the microcave. We open the microcave, we can reach lower than the part of the trigeminal nerve. And for the part below the trigeminal nerve, maybe we drill a little bit of the petrous apex, just I showed in my video. And also we can reach the level about the abducens nerve. And for the lower part,
goes down to the lower cranial nerves.
We can use the retrosigmoid approach to remove either the lower part of the tumor and also the part lateral to the internal acoustic meator. For your case here, the lateral part to the internal acoustic meator is very difficult to remove through the subtemporal approach, even with the drill of the apex. So for this case, now I prefer to use the two simple, combine subtemporal with retrosigmoid approach.
Okay, okay. That's interesting. Okay, so the votes are in. So Imad, tell us, what would you have gone for?
I will go for the pre-sigmoid approach without any hesitancy because this lesion is going beyond the level of the facial canal. So it goes down. I need an access down. And it goes high up in the subtemporal area. It's not a small component. And I need to tackle that dura because most of the supply comes from this dura. So I will win the two situation. The only backdraw of this procedure is the time consumption.
Yes.
You need to do a lot of drilling But again, this is the principle of skull base we used to apply, take more bone for the sake of less retraction, because any approach for this sizable tumor will be entailing a lot of retraction, and you need to have that wider exposure. This is what I feel about it. So that's specific lesion.
I agree. So as we discussed, I mean, it's interesting what G said. I mean, I feel any sort of fetus apex or temporal approaches, for me anyway, it's very hard to get below the level of the IAM. And retrosigmoid, of course, fantastic approach, but it's given how medial this comes, I really favor this sort of pre-sigmoid and middle fossa craniotomy and cutting the tentorium for the reasons Emad has said nicely. You get to the blood supply, less retraction, you're coming around the front, it gives you a nice window upwards. But what about nobody mentioned really the end
let me.
Sorry, who was that?
During many years when Amirati and Majid Sami described the presigmoidal approach, at that time I was very enthusiastic with the presigmoidal approach, and I did. And in some cases, transpetrosal approach also. But after all that experience, I came back to the retrosigmoidal approach, sometimes with, as our Chinese colleague has said, maybe with the combined approaches is necessary. Sometimes it's not necessary, because you can even, in some cases, in the upper part of the tumor, just to drill in the petrous bone, and you can go and remove that tumor. So this is my opinion. So I start at the time of the Ansami description, or transphenoidal, transpetrosal in some cases. And the last years I came back to the traditional
retrosigmoid. Now, nobody really talked about the endoscopic approach, which I don't think is a good one for this.
I did mention to you the joint venture but that sizable tumor up, that's what deprived me from using this one. A retromastoid with the incision of the tent from below, and use the 30-degree endoscope to look up.
Well, I'm talking about coming straight through the clivus anteriorly, which I think is a very bad idea for this tumor. But let's just ask the question. Let's say, well, it was didn't go so high. But there are lateral restrictions, I think, but I'd be keen to hear what everybody else thinks. I think there are lateral restrictions. So then my next question for the quiz is, what are the limitations laterally in the endonasal approach? And what is the main one, maybe, I should say. Let's see what people think, whether they agree or not. Basilar artery, that's interesting, okay. Yeah, the lower cranial nerves, all right. What do people think about this? Okay, so it's quite a bit of the votes are in here. Sebastian, I see you're back. Okay, what are your thoughts on this, Sebastian?
Sorry, I had some connection issues.
No problem. What do you think about the lateral limitations to tumors in the midlines of the clivus using an endoscope?
For endoscopic endonasal, everything that is lateral is a limitation. Huh? So
what structure?
Nerve, inferior petrosal sinus, 7 on 8, 6 nerve. I think it's a bad, but I think you have the same opinions than me. It's not a good approach for endoscopic endonasal. It's a lateral lesion, petroclival. By definition, it arises from the petroclival region or tip of the petrous apex. So you will have a CSF leak for sure. If the idea is just to debulk the lesion, most likely you will not succeed and have some CSF leak. So the tumor problem will not be solved. And in addition to that, you have a 20% CSF leak. I think endoscopic is nice, in my opinion, in my experience, is nice for pure clival lesions which are not so often. It's very rare compared to petroclival, but I did a few. And for those, endoscopic is nice because you don't have to deal with the lateral limits you're talking about.
Yeah, and I agree. And what does the panel think about debulking? Because these are tough tumors. They're not going to collapse down, aren't they? So like you said, debulking is a bad idea, isn't it? Does everybody agree with that? What do the others think about this debulking issue?
Debulking, not for meningioma.
Yes. These are tough tumors. They don't collapse down. It's a very bad idea. Right, I think we're running short on time, but I just wanted to highlight some of the points that we've just discussed there. That, you know, this would be a very bad approach for this sort of tumor. We talked about how the sixth nerve, low cranial nerves, but and I also find it difficult dealing anything coming lateral to the intradural and lateral to the inferior petrosal sinus. I find that difficult. It's an interesting bit of anatomy. You can see how the sixth nerve goes through it. So you can see how in inferior petrosal sinus sampling for some pituitary tumors, you can very, very rarely see sixth nerve palsy, and that's the anatomy that explains that. Okay, I think in the interest of time, I'll go a bit quick. I went for a combined middle fossa and pre-sigmoid approach. You can then decide if you're just going to drill the retrofacial air cells and air cells here and keep the labyrinth or take the labyrinth, or if you're coming, you know, for the ascending carotid, whether you're even going to go transotic. This question now is, what is this structure here that you have to preserve in this approach? So what is the structure shown there? I think in the interest of time, we won't waste. Sorry? Did you say something, Roy?
No. I was just saying hello to Lorenzo, who just joined us here.
Yeah, quite rightly, it's the descending portion of the facial nerve. So that's absolutely right. You have the second genu and the facial nerve going down the stylomastoid foramen. Okay, and then we talked about sectioning the tentorium. I won't go through that again, but I'll just ask quickly, and we've discussed some of this. You can put as many answers as you like here. What are the advantages of cutting the tentorium? Put as many answers as you like. So I know at least 3 of us here like this. Oh no, Victor, you as well. At least 4 of us here like this approach. Anybody want to comment on what they feel? I know we've already discussed some of these things. What do they feel the big advantage are of this combined middle fossa and pre-sigmoid approach where you cut the tentorium for these tumors?
Isn't it part of the approach? You always cut it, right?
The tentorium, yeah, always cut the tentorium.
Yes.
And what's the big advantage of cutting the tentorium? In fact, you can do more than cut. You can actually excise part of the tentorium. I know Sebastian likes to do that. I like to coagulate it down. Emad?
Excise.
Yeah, you excised it.
In my opinion, sorry, Emad. Go ahead, Emad.
No, go ahead.
I am one of the main advantage, in fact, in my opinion, is missing here. Is it's that if you cut the tent, you can unlock the junction transverse sinus, sigmoid sinus, and you can retract it posteriorly and inferiorly, because this approach is based on this upward corridor below the temporal lobe. And you can only do that if you transpose the sinus. And to transpose the sinus, you have to unlock it from the tent. Then everything you said after the devascularization, resection of the tent, which is in fact the dural base, is extremely important and increase the view. But what increase more the view is that you can transpose the sinus posteriorly and use this space between temporal lobe and cerebellum.
Yes. I think I sort of talking about that.
To add to this one for the young neurosurgeons, this is very important when you plan this procedure to make sure there is no extreme lateralization of the sinus. And this is what they call it, the Trotman triangle. So you have to make sure that you have this triangle to drill out, and so you be pre-sigmoid. The other things, people not skeletonize the sigmoid down almost to the jugular bulb, they won't be able to mobilize the sinus medially. as suggested and nicely said by Sebastian.
Yes, that's right. Drilling, and in fact, you can even drill medial to the jugular bulb to give it just a little bit more space for your dural opening. So that's a very good point. Now, the one I don't agree, and people can disagree with me here. I actually don't think these are advantages of the approach. I agree, you get this fantastic working angle above and below 5, and you certainly devascularize the tentorial supply. But I actually think I worded this quite carefully. I said increased working angle above and below 9 and 10. Your view below 9 and 10 is very bad, actually, in this approach compared to a retrosigmoid, for example, because the jugular bulb is in your way.
That's why.
Sanjeeva.
Yep.
That's why the original. Sorry.
So I think this is a great discussion, especially between the more advanced specialists. But for the younger, less experienced surgeon who just starts skull base, so hasn't done the fellowship in a top place, I think G's approach is actually very reasonable. Combine a suboccip and get in from the front somehow through a subtemporal or even a extended terional approach. Some form of simple, doesn't require that amount of drilling, preserves the hearing. You may get away with less invasiveness, and these are the workhorses of your two approaches to the same location. So I would not necessarily say you end up with the perfect approach, but it's a very safe approach, and you will get most of this tumor out. So I think that should be one of the things we should give out as a recommendation. Safe is always what trumps the most.
Yeah, no, absolutely. And I think it's a theme throughout the talk that you have to do what is safe in your hands with your team. But just point out that that's not an advantage, and you can't get below it. And you do not get to the clival blood supply early. You get to it at the end.
May I add one thing for your comment about the lower cranial nerve? You are right. The original description of Hakuba approach, he complemented with retrosigmoid craniotomy.
Yes.
So we do the pre-sigmoid with the retrosigmoid, so you can access the lower part and guarantee the integrity of the lower cranial nerve if this approach was not adequate.
Yes, I agree.
I may just add one thing. The retrosig, in fact, for a combined petrosal is absolutely necessary, because if you don't do a retrosig exposure, you cannot transpose the sinus. So with retrosig, you have the advantage first.
Yes.
You can get CSF very early. This is something I do. I start with a retrosig incision to get CSF from the 9, 10, 11 cistern, and then, as Imad said, you can go to the lower aspect of the clivus, and you can transpose.
Yes.
The other things for Eckhart, I know we like to show the simple things, but they have to understand such a tumor with this sizable tumor is not for beginner. They have to understand, they have to work under supervision and learn the technique. This is a benign lesion, and the best outcome will be with the best approach. We should not compromise on the approach because it's difficult for the trainees, but it's the best for the patient.
Yes, absolutely. Okay, I think it's for too long. I hope you found it helpful. Sorry, who was that?
I think that you could have a wide view, not only in the answers we can see in the panel, but also if you could the tentorium, you are going to respect the fourth cranial nerves and also the vascular and in the crural and ambient cisterns. You are going to get more control, distal control of these arteries, and they are going to send you to a most sure approach, a most sure decompression of tumor.
Yes, absolutely. Okay, and this was just to show the big angles on either side of the trigeminal nerve, and here to show that most, I left some tumor onto the clivus here, but to show you get very high, all of that comes out. This is PCA coming off. So you get very high nicely. Obviously, you get the lower bits as well. Okay, I think it's gone on long enough. I hope people enjoyed that. Thank you very much. I will stop sharing
Okay. Before we conclude, I just want to reassure that all the attendees and young neurosurgeons, please fill the form for evaluation. We are dependent on the quality of the presentation, on your feedback, so we can plan the next events in 1 month's time. And once we receive your evaluation of the course, we will submit to you your certification. I thank all the panels. Thanks for all of you that they left their works and family and stay along with us. Sebastian, Ramesh, Thomas, Takashi, Sanjeeva, Victor, Armando with us as well. I'm seeing Armando Paso here. Nice to see you. Igor, nice to see you. Yitang, Pablo, he is the master. Without him, we could not be on Zoom today. And Ek from Canada. Salman, thank you. And Moody, thanks for your contribution to this discussion. And Keki, he was with us as well earlier. I don't know whether I don't see Vladimir. Well, of course, Vladimir is an essential on this committee. Pablo wants to say something.
Yeah, I'm reading some questions about the feedback form, just to let them know that Igor and Sanjeeva have been working on that, and we will mail all of them the feedback form. So we will mail you the feedback form as we have your emails. They were asking, where is the form? That's it. We will mail you.
Okay, well, have a good evening and a good day. Take care.
Bye-bye.
Bye-bye. Good night.
Excellent.
Thank you.
Take care.
Thank you for joining. Arigatou gozaimashita. Thank
Arigato, Takashi.
Sebastian,
Thank you.
read
See
your
you later.
messages.
Arigatou. Oyasumi nasai. Sayonara.
Bye-bye.
Bye-bye.
Thanks, Pablo.
Bye, Ramesh.
Thank you, Matt. Keep in touch.